Start. Good morning. Yeah, hello everyone, whoever has logged in. Today is the second day of our CME come workshop. And today would be basically we are going to deal with a workshop of grossing of resected specimens, which we do get in day-to-day routine practice in any surgical setup. And it's very important to do a proper grossing and proper sampling so that one can also do the interpretation properly depending on adequate blocking and trying to avoid unnecessary blocking from the resected specimens. And so I hope everyone who has logged in gets benefited from these 5 sessions which we are going to have today. And the first speaker is going to be Dr. Rajiv Kausal from TMC Mumbai. And so we start from the uppermost part of the GI, that is the esophagus. So he's going to talk on esophagectomy specimens grossing and reporting. Rajiv, stage is all yours. Please start.
Thank you, madam. And at the outset, I'd like to thank Dr. Kim, Dr. Rotra for giving the invitation to be a part of this excellent workshop. And yesterday there was excellent. Is my screen
your voice
visible?
is breaking up. Your voice is breaking up. Just see.
So I'll switch off my video.
Now is better. Now is better. Now is better.
Okay. So I'm talk on the grossing of esophagectomy specimen. Before I go into the grossing of esophagectomy specimen, I just like to give you some fundamentals of the grossing, which is applicable across all the specimen types. So that includes the first, whenever any specimens come to you, first we have to orient it properly, then take the measurements of the lesion as well as the whole specimen. And if you are dealing with the neoplastic specimens, then the inking of the specimen from the external aspect is very important because it gives a fair idea to comment on the margin status when it comes to the slides come under your microscope. And finally, the adequate sampling of both the lesion as well as the margin, so that we can offer this is a snapshot of the information which is given in our report. Means first is it confirms the diagnosis which is mostly established by the preoperative biopsy. So the idea of the specimen is not only for the confirmation of the diagnosis, but it confirms the diagnosis which is offered on the biopsies. And then come the most important role of the surgical specimen is the adequate TNM staging, margin assessment, and comment upon the adverse prognostic factors which assist in the treatment. And now with this current era of in current era, many patients receive neoadjuvant therapy either in the form of chemo, radiation, or targeted therapy. In those cases, we have to comment on the response assessment. So as we know that esophageal cancer, it is one of the very poor cancer with a very aggressive clinical course with a poor prognosis. And multimodality treatment, although it is used, the outcomes were not very good. But recently, with the use of neoadjuvant therapy, there is a significant decrease downstaging of the primary tumor, and which also destroy the occult lymph node metastasis. Hence, recently, especially in the last 8 to 10 years, we have seen the esophageal cancer has a very good clinical outcome. Now, before I go to the actual grossing of esophageal specimen, just to brief you about the surgical anatomy, we know that esophagus is divided into the 3 part. After cervical esophagus, it is upper, mid, and lower esophagus, which ends at the gastroesophageal junctions, and stomach continue from it. So, what is the very relevant or important thing about anatomy of esophagus is that the lymphatics is very unique in this part of the intestine, and there is a very significant crossover of the lymphatics in the submucosa as well as in the adventitia. So how it is relevant for both for the surgeons because there is a significant amount of the crossover of the lymphatics. Then the nodal metastasis can be very extensive, and hence the clinician, the surgeon has to do extensive lymph node removal from the whole segment of the along the whole segment of the esophagus. Another important thing is due to this crossover, there is a possibility that there can be skip lesions can occur in the esophagus. So these are the two important points which we need to remember. Next is the type of the specimens which are type of the specimen which you come across. They range from the partial esophagectomy to total esophagectomy or esophagectomy with the gastrectomy. So these are the three common specimens which we encountered. As coming to the first part as orientation, orientation is usually not a problem in esophagus because especially if it is the esophagectomy with the gastrectomy, only if the surgeon has done the partial esophagectomy, then they should mark the proximal and distal and separately. Come the fixation of the specimen, that is the first and the most important thing. So what is recommended when esophagectomy come? Am I audible, ma'am?
Yeah, you're fine, Rajiv. Yeah. It's fine.
Okay. Yes, just cross checking. So the fixation is the first and the foremost important aspect, and so the specimen, it is should be immersed in the sufficient amount of the formalin. And so what care during fixation we have to take? So if you immerse the specimen, because this is a tubular structure without any supportive innate supporting network, so the tube can curl on itself, and then you might face problems during the grossing and adequate sampling of this. So how can you avoid that? So whenever the specimens comes to you first, and you go both proximal and distal end of the specimen, try to put cotton gauze immersed soaked in a formalin from the both the ends from the distal and proximal end. And now how to keep the specimen intact? It is recommended to fix this tubular structure by using some pins and on a cardboard or a wax board, so that when you put the specimen in the formalin, it remains straight. So during sampling, it helps to a lot. So one important thing, this is the specimen of the esophagectomy, partial gastrectomy in the fresh state, and then the outer aspect, because the especially of the esophagus is a raw or rough area that makes it a surgical margin. So we have to ink the all external aspect of the esophagus. Next is about the how to go about the grossing of these specimens. It is now recommended that if you do the transfer sectioning right from the proximal end to the distal end, it gives a very good orientation with respect to the all the layers of the esophagus. But there is another method also. You can open the esophagus along the length as well. So in this you can see there are multiple slices of the esophagectomy specimen has been done, and
yes sir.
So there is a from till these segments we are not able to make out any tumors, but this is the area from where the tumor has started appearing. So as I showed in the earlier picture, so these slices should be thoroughly spread on your working desk, and then it's recommended to label them so that you can get an idea about the exact tumor size, as well as the distance from the of the margins. So roughly it is recommended to take roughly around 3 mm thickness of these slices. And like in this picture, in case if there are 9 slices which are showing the tumor, so you get an idea about the tumor size as well as about the distance of the proximal as well as the distal resection margin. Another method which I mentioned about, that you can open the esophagus along its length. Although the advantage of this method is that you can see the tumor as well as the normal mucosa in toto on a gross examination, but only problem which can you can encounter is the orientation with respect to all layers cannot be as precise which we get with the transfer sectioning. So there is no harm. You can use your judgment depending on the tumor type, whether to open the esophagus along the length or along the in using the transfer method. So each has its advantage. Opening the longitudinal method has an advantage because it gives orientation of the tumor with respect to G junctions, and you can at one go you can see the normal adjacent mucosa very clearly. And the transverse method has an advantage that it gives a very good idea about the various parameters which we assess for the TNM staging of the tumor. This is a snapshot why just to show a transfer section of the of esophageal specimens. And so the T size is not decided in the esophagus or even in the whole of the GI tract by the tumor size, but it is decided by the depth of invasion. So whenever we are taking the section, we have to be very clear in our mind that the sections which we are taking should be able to give us a fair assessment on the depth of invasion. And especially in the, because the green circle which are drawn on the outer aspect is very important because it becomes a circumferential resection margin, because in esophagus there is no serosal lining or any protective peritoneal lining. So we have to include this CRM or the circumferential resection margin in the section which we take for the adequate assessment. So then moving on to the type of sections we have to take. So it is recommended to take minimum 4 tumor blocks with including the deepest point of invasion. So because that will decide the T stage of the tumor with CRM and the gastric serosa if the tumor is located in the G junction, interface of the tumor with the adjacent mucosa, because it helps to see if is there any dysplasia in the surrounding mucosa. The next is about the margins. So in esophagus there are 2 margins which are important. One is the CRM, that we call as circumferential resection margin, and so which is the as I mentioned, as showed in the earlier picture, that this is the outermost aspect of the specimen, and which is painted in a black ink. The other 2 margins are the proximal and the distal resection margins. So if the tumor is far away from the margins, you can take shave margins, but if the distance is less than 1 centimeter, it is recommended to use take radial margins for that. Then always take we have to record the relationship of the tumor with respect to gastroesophageal junction, because why it is important, because it helps in the categorization of the TNM, whether to use the gastric classification or gastric system or the esophageal system, which I'll discuss a little later. Any abnormal area which we feel in the esophagus, like if you see a salmon pink patch, that is likely to represent gross as a Barrett's mucosa, and those areas should be sampled, and adjacent areas of the stomach as well as the esophagus should be sampled. Next is about the once you are done with the next thing is about the lymph nodes. So for each any oncology specimen, there should be adequate sampling of the lymph node should be done. And in esophagus, it is recommended to at least sample 10 nodes. So it's recommended to sample as many as nodes as possible, but minimum 10 should be there. And especially if it is the early stage like cancer like T1, in those it is recommended as a 10. If it is T2, then 20 and 30. So although these values are not very fixed for esophagus as for the rest of the GI tract, like in the for the colon we say the minimum of 12 nodes are important. But we should try to obtain as many nodes as possible, because nodal involvement is one of the very important prognostic factor. And many times surgeons send the notes separately, and not they are not submitted as the specimen. So those all separate groups should be submitted separately. Next is a few points about the many times, as I mentioned in the beginning of my talk, that many cases now are say they receive neoadjuvant therapy. And so for the response assessment, the pathological examination is the gold standard for the assessment of treatment response. But especially in the esophagus, we have seen the tumor shows very extensive, very good response to the chemotherapy, and many times it becomes very difficult when the specimen comes to us to identify the tumor. So especially if you are finding it difficult to identify a tumor with a histological, in a case of histologically proven esophageal cancer, that means the patient has a good clinical response. So as I mentioned that on the response, the gross evaluation or exam will be gross appearance will be different. So if there is a bulky residual disease, that means there is a hardly any response. And if you don't see any tumor grossly, that means patient has excellent clinical response to the therapy. So if how to identify, because there can be problems when you are not able to identify these areas of area of the tumor. So how to sample these do the sampling in such cases? Always try to go back and check the pre-treatment imaging, especially endoscopy findings where exactly the tumor is located, and about the site of the previous biopsy. And grossly how you can identify or sample these areas. There can be areas of mucosal irregularity, congestion, ulceration, or thickening. So we have to sample these areas so that we don't miss any tumor. And in addition to the primary tumor, there will be effect of the treatment on the lymph nodes as well. So in these cases, sometimes we do get a low lymph node yield, but we have to make a best possible attempt to sample the lymph node. And if you're not grossly able to find out the lymph nodes, you can sample the entire adventitial fat. But this exercise should be done once you have taken the samples for the primary tumor, because that might disturb the orientation of the tumor. So I'll just show you the video so that the whatsoever I told till now you get a fair idea how to do it in the practice.
This is a specimen of esophagus with proximal stomach. The staple gastric or distal margin cut open at the time of fixation. The length of the esophagus and the length of the stomach along lesser and greater curvatures should be recorded. The external surface of the esophagus is examined for any obvious abnormalities, and all staples should be removed. The esophagus is painted and the ink is either air dried or fixed with 2% acetic acid. The specimen is then serially transected from proximal to distal end of the esophagus. The slices should be approximately of equal thickness, that is 3 to 5 millimeters. Each slice is laid out sequentially for subsequent examination. This is what it would look like when the slices are all neatly laid out. The first slice is the proximal cut margin. The tumor needs to be felt as well as seen, and the depth of invasion into the wall of the esophagus, i.e. the layer involved, is recorded. The slices without tumors are from 1 to 10, and the slices with tumors are from 11 to 19. Hence, on summation, the proximal cut margin would be 30 millimeters away from the tumor if each slice measures 3 millimeters, and size of the tumor would be 27 millimeters because that is 9 slices. Sample the distal cut margin. The cut margins are shave margins, but if the tumor is less than 1 centimeter, then it is advisable to take radial cut margins. This is so that we get a definite idea of the distance of the tumor from the margin. Take at least 4 sections of the tumor. The slices easily fit into the cassettes. If the slice is too large, it can be bisected and the slices can be taken. It is important to get the ink surface, which is the circumferential resection margin. If no tumor is identified, as often happens in cases treated with chemotherapy or radiotherapy prior to surgery, then find out the site of original tumor from the CT scans and take numerous sections from around that area. The sections taken should be of 1, the tumor with a circumferential margin, 2, the proximal cut margin, 3, the distal cut margin, 4, cardoesophageal junction, 5, any other abnormality identified, and then of the lymph nodes that have been supplied separately.
So this is now I'll just briefly discuss each individual parameter so that we get a fair idea about the how they have an impact on the clinical outcome. So first and foremost is the tumor size. As we know that we have to record the tumor size in all the oncology specimens, but the tumor size is not the main the core criteria for esophageectomy specimens. So although it is agreed that tumor it is smaller in size, the outcomes are good as compared to the large size or bulky tumors, but this is not a criteria for the TNM classification. As I mentioned that in some time in esophagus, we might get a multiple tumors in such situations. We have to what we have to do if you see more than one tumor or one lesion in the esophagus, you have to measure them either separately, and the height of the tumor, the length of the tumor from the highest position to the lowest position should be recorded. Next is about the proximal and the distal margin. So if the tumor, if it is involving the proximal margin, you can see that as compared to as compared to the margin negative tumor, the outcomes are fairly bad, and irrespective of the distance of the tumor from the primary from the margin, we have to sample the proximal margin, because there are chances of a discontinuous foci of the carcinoma as well as skip lesions. Distal margins, although the distal margins are usually free, especially if it is a commonly occurring squamous carcinoma, and we have a specimen of esophagectomy with a partial gastrectomy. But in case of the adenocarcinoma, we have to be very careful in evaluation of the distal margin, especially if it is a poorly differentiated or the signet ring cell adenocarcinoma, because these tumors can show the submucosal spread, and hence the evaluation of those margins should be done very carefully. And as you can see, if the margin is involved in case of adenocarcinoma, again the outcome is dismal. Next margin, which I mentioned earlier also and stress, is the circumferential resection margins, and this is a very important margin for the in the esophagus. And when will you call this circumferential margin as a positive? So now it is well accepted that even you don't need to see the tumor at the ink surface or the margin, even if it is less than 1 mm from the margin, it has to be called as involved. And why being it is said, because when the survival analysis of the tumor which are either at the margin, which is shown in the green bar, as well as at the with less than 1 millimeter, they are almost similar. So either that if you see the tumor at the margin or even within the 1 millimeter, it has to be called as as involved margin. Next is about the stage of the esophageal or the gastroesophageal tumor. So they are staged from T1 to T4. T1 tumors, they are restricted to the mucosa, where T1A is if only the invasion in the lamina propria, and T1B if it reaches to the submucosa. T2 if the tumor is reaches only up to the muscularis propria, and T3 if it is in the adventitial fat, and T4 if it goes to adjacent organs. So we have to keep in mind, if a tumor which is involving the CRM, it doesn't change the stage from T3 to T4. So T4 is only if the tumor invades the adjacent structure. Next is about the nodal staging. If 1 to 2 nodes are involved, that it is N1 disease, and 2 when 3 to 6 nodes are involved, and 3 is 7 or more. So we have to at the end of your report, we have to make sure that you offer the TNM, because it helps the clinicians to start that therapy very easily. And as I mentioned, that T stage and N stage, they are the very strong predictor of the survival outcome, as you can see with these two charts. Another important thing which is coming, which is relevant as a pathologist for us, which is now proposed even in the new TNM staging, that we should always mention the grade of the tumor, because it in now in the new staging category, there is a subcategorization is based also based on the grade. So in esophageal and gastroesophageal tumors, we have to make sure that you offer the grade of the tumor. In a short about the TRG, that is the tumor regression grading. So there are whenever a patient has received a neoadjuvant therapy, we have to give a response assessment, and there are 2 or 3 systems in which the TRG or tumor regression grading can be given. And the one is the 5-tier system, that is called grading system of Mendard, and TRG1, where when there is a no viable tumor, as compared to the TRG5, where there is extensive residual tumor without any fibrosis. So this is a 5-tier system. There's another system which is called as modified Ryan system, and it is now being observed that this system has more reproducibility with the less inter-observer variability. So so you can use any system for reporting of TRG, but you have to specify that which system you are using. So you should write in your report like TRG by Mendard or Ryan, because one is 5-tier system, other is a 3-tier system. And when as I mentioned, especially in the case of neoadjuvant therapy, if you are not seeing the tumor, you should and submit the entire tumor bed should be submitted. And when sometimes it do happens that on the surface that there is no tumor, but in the deeper layers there can be presence of tumor. So especially in the in the treatment post neoadjuvant cases, it is recommended to not only sample the superficial portion of the lesion, but also the deeper layers as well. And presence of acellular mucin or keratin doesn't connote that this is a viable tumor. You have to see the viable tumor cells, only then it need to be called as a positive or residual tumor. And if there is any doubt, IIC can be attempted, but it is not mandatory. Just in a brief about the G junction tumor. So in these tumors, there can be 3 clinical scenarios, like I have shown a tumor which is involving the which is going into the esophagus, but the epicenter of the tumor is more than 2 centimeters away from the G junction. And another scenario like a B, where the tumor, although it is close to the G junction, but not directly going into the esophagus. So, and there's a third scenario where the epicenter of the tumor is within 2 centimeters of the G junction, as well as the tumor is going into the esophagus. So how do you categorize the? So in these first two situations where either the epicenter is more than 2 centimeters away, irrespective of the esophageal involvement, or if it is the tumor not the esophagus, they are classified as gastric classification. So whereas the tumors which has epicenter within less than 2 centimeter from the G junction as well as and invading into the esophagus, they are categorized into according to the gastroesophageal classification. Just briefly about the changes which has happened in the TNM 7 to 8. So earlier the cutoffs for GE junction tumors were 5 centimeters, so which has been reduced to 2 centimeter now. And otherwise there are no major changes in the TNM 8 AJCC classification staging system, except that the one point which I highlight now, it is important to recommend the grade of the tumor. And for the nodal stages, only the N1A and sorry N3A and N3B categories were introduced. And finally, whenever we are dealing with any esophagectomy specimens, we have to make sure that your report convey all these parameters ranging from the type of procedure, location of the tumor, size and appearance, what is the histological type and grade of the tumor, maximum depth of invasion, because that decides the TNM stage of the tumor, LUI and PNI, because it becomes many times becomes a very important adverse prognostic factor, especially if it is a node early stage cancer and node negative tumors. Resection margins, proximal distal and circumferential margins, and even if there is a presence of dysplasia or metaplasia at the margin, it need to be conveyed very clearly. If about the status of the background pathologies like adjacent mucosa, is there any dysplasia or not, and if it is a dysplasia, is it a high grade or low grade, and presence or absence of Barrett's esophagitis, the status of the lymph nodes and treatment effects, and as I mentioned at the end, about the TNM. So with this, I end my talk, and just one message for especially for the resident: don't experiment with the specimens. You first check how to gross it, learn it from your from seniors, and then only go for the actual grossing. So you might end up ruining a specimen if you don't know how to gross it properly, and if you're these checklist which I mentioned, if that checklist is not in your mind. Thank you very much, and if there are any questions, I'll to take them. Thank you.
Yeah, Rajiv, it was wonderful. You have covered almost every aspect of it. I think there is in the chat box. Can you see the chat box? There is one question, I think.
I'll just try.
Just see, there is one question in the chat box.
Can you not able to? Okay.
Yeah. Can you see it? Otherwise, do I read out?
How to take sections ideally from G junction, cross section or longitudinal. So from G junction, I personally feel longitudinal sections helps a lot, because it gives a proper orientation with respect to the post gastric as well as the esophageal mucosa. So what you can do, you can transversely cut it near to the G junction, and then you can take a longitudinal section on that area. There is another question. In G junction tumor post NACT status, how accurate is the tumor status tumor epicenter calculation? Yeah, so sometimes it might be difficult. So better to so if you keep so these pictures in your mind, if the tumor if it is less than 2 centimeters away from the G junction, and if it is invading into the esophagus, so that now the criteria are very clear. So one, if is the epicenter less than 2, and if it is invading the esophagus, then only we have to call it categorize as per the esophageal cancer. But especially, I agree with you. Sometimes it can become difficult, especially for the adenocarcinoma of the G junction. About the epicenter. So squamous carcinoma, we don't face much problem, but evaluation of for adenocarcinoma can be problem, and sometimes they have like a polydifferentiated adenocarcinoma which shows some mucosal growth. So those are another problematic areas which you come across. Okay, there is a
Yeah, I think you have to keep on answering them.
yes, no problem.
Ah.
So another question is, sir, can you tell again how to approach when there are more than one tumor focus foci? So if there are more than one tumor foci, because they can be a skip lesion. So one thing is you have to measure individual lesions as well as so give the dimension of individual tumors. Second thing, you have to take the dimension from where the first tumor you can see the first tumor, the proximal end of that, and the last tumor. So both, so that length we need to mention across how much segment of the esophagus there was a presence of a tumor. Should another question, should we do AJCC staging as well on post neoadjuvant therapy esophagectomy specimen? Yes, we have to give the staging, but the before PT TNM, there is need to add YPTNM. So the rest of the staging parameters are same, but if it is post neoadjuvant, we have to add YPTNM. Can't the tumor shrink? Can't Next question is, can't the tumor shrink after NSAID? Yes, definitely. And esophagus failure tumor, especially squamous carcinoma, we have many times there is a very excellent response. That's why there is a need to sample the area, even if you are not able to evaluate the tumor grossly. So many times you see an excellent response, and in those cases, tumor can show marked shrinkage. Next question is, what should be T stage of esophageal tumor involving the gastric cirrhosis? So even if it is involving the gastric cirrhosis, if you feel that if the epicenter is less than 2 centimeter involving the esophagus, it has to be categorized as per the esophageal staging, not as a gastric staging. If so, in that case, if you are seeing a tumor in the going to the adventitia and even involving the cirrhosis, it will be still be T3 tumor. So next question is, if only mucin or keratin is present in the lymph node, it will be regarded as negative. Only viable tumor cells need to be there, then only it is regarded as positive. And the last question, if we get less number of nodes in the post, just one second. If we get less number of lymph nodes in post-neoadjuvant space, uh, can we still do TNM staging? Yes. So in such situations, first thing you have to make an attempt to resample or regross the specimen and try to look if there are any nodes. Even if you are not able to get the nodes grossly, you can submit the adventitial fat, and in the report you should mention that despite of extensive sampling or despite of the efforts which you have put, so this should be conveyed on the report to the clinician. Like you can I usually, whenever I get a less number of node, I put in my report, despite the extensive sampling. You can even mention the number of blocks which you have taken for the nodes, like 5 blocks, 10 blocks. Only five nodes were evaluated. So that means clinician know that you have put maximum efforts from your end, and there is no point to go back and get it reviewed. Next question is, after NACD treatment, G junction, would it be false tumor size and epicenter calculation after the treatment, or we need to compare pre-NACT tumor size? So tumor size, as I mentioned, although tumor size is important to record, the staging is decided by the depth of invasion. So size of the tumor is not very important. It is the depth of invasion. Your section should be sampling should be done in such a way that you should be able to to interpret the depth of invasion precisely. Another thing, same thing again coming as an epicenter calculation on after treatment. So I mentioned earlier, sometimes it can be problematic, and you have in those situations it is recommended to go and check the pre-imaging findings, especially the endoscopic findings where the tumor is was located, and evaluate your things like that. Last question: should we grade new post-neoadjuvant tumors? Although it is recommended to put, but post-neoadjuvant sometimes the grading can be challenging because there can be therapy-related effects. In those cases, usually at our center, the clinicians go with the on the grading given on the biopsy findings. So
that's all. Yeah.
Yeah,
Quite a
ma'am,
few.
I'm
Quite
excited
a
to.
few.
Yeah,
Quite a
so
few
there are a lot of
questions.
questions. Lot of questions
Anybody
on the.
want chat box, huh? Yeah, good. You have given them, I think, very good answers. Yeah, somebody, I think there are people who are admiring your presentations as well in the chat box. Yeah, it was a wonderful presentation. Yeah, very good. Everybody is admiring you. Yeah, we also agree to that. It had been a wonderful presentation and very informative, Rajiv. And thank you very much. Huh? Okay,
Thank
we'll
you.
go
Thank
to
you.
we go to the
Yes.
next session. Yeah.
Yes.
Next session is again grossing of gastrectomy specimens, and the speaker is topic दिखा दो एक बार कोई थोड़ा वो अपना उन लोगों के पास proper वो नहीं होता. They want to see the topic.
How can I stop my share? Okay, it is.
Yeah, you stop sharing yourself. That we go to the next one. Okay. So the next session is on gastrectomy specimens, and the speaker is going to be Dr. Gitanjali Gude from Hyderabad. Gitanjali ka I think एक PowerPoint है एक बार दिखा दो राखी. The same thing only, but दिखा दे. Yeah, it's the one which we have seen yesterday, and so may not be anything new for people who had attended yesterday's session. And so I think now, Gitanjali, are you ready?
Yes, ma'am.
Go ahead. Start sharing your slides. Go ahead.
Just a second, it's loading.
Otherwise, we have your presentation also. Is coming.
Okay.
He's starting to share. Huh?
Yes, yes, yes.
Yeah, it's coming. It's coming. Everybody has been sent a program also. They still want to know what do I do here? We can't keep on sending everybody one.
Can I get the presentation shown?
You want us to show your
Yes, ma'am.
presentation?
Yes, ma'am. Yes,
Yes,
ma'am. I don't.
Madhu, you can- let
ये तो ऑलरेडी 75% ओपन हो गया ना आई थिंक
It got shut
This-
down.
pentose phosphate pathway is what? लेकिन this is pentose phosphate pathway है. It is nothing to do with
These
grossing
are-
of gastric nerve. It's coming. That is pentose phosphate pathway. High
It's
level
the
direct
wallpaper.
hanging a meeting, preparing a meeting. I think it's coming. Yeah, it's coming.
Yeah, yes, ma'am. It's opening. Just.
Yeah, it's coming. It's on.
Sorry for the glitch. It just. So thank you everyone for this opportunity. Thank you the organizing committee for having me present this grossing of the gastrectomy specimen. And we had this excellent presentation by Dr. Rajiv Kaushal. And the basics of the grossing he has covered, which should be applicable to all of the specimens regarding the marking of the sample, specimen dimensions, and the sections to be taken. So whatever I have described in this chapter are mostly adapted from the grossing of the surgical oncology specimens book from the Tata Memorial Hospital, and all the staging is from the CAP Cancer Reporting Protocol and in accordance with the AGCC Cancer Staging Manual of the 8th edition. So before grossing of the stomach, we should acclimatize ourselves with the normal anatomy of the stomach. So the stomach is divided into four major parts based upon these lines which you can see. So first is the cardia, the tumor, the part of the stomach which is close to the esophagus, where the esophagus is attaching to the stomach, is the cardia, and it is present just below the diaphragmatic opening of the gastroesophageal junction. To the left of the cardia, we have the fundus. So if we draw a line from the esophagogastric junction towards the left side, the whatever portion is above it is the fundus. So here we can see the esophagus is a tan white color kind of mucosa, whereas the stomach has a salmon pink color kind of mucosa. So in cases where there is a Barrett's metaplasia, what we see is the salmon pink coloring of the lower end of the esophagus, which is a morphological gross clue for Barrett's esophagus. And the portion which is present above this, the dome-shaped part of the stomach, is the fundus. And from below the fundus, if we draw a line, this is the dip which is present, which is called the incisura angularis. If we draw a line from the incisura angularis up to the greater curvature of the stomach, the imaginary line, whatever comes above it is called as the body of the stomach. So in the body of the stomach, it is very important to note all these rugal folds. So here on the lesser curvature, we have almost the longitudinal rugal folds, and rest of the portion we have almost like transverse to diagonally placed rugal folds. And from this line to a narrowing portion, which is called as the sulcus intermedius, if we draw an imaginary line passing from there to the greater curvature, this white portion is called the antrum of the stomach. And beyond that, whatever the funnel portion of the stomach is present, up to the gastroduodenal junction is the pylorus of the stomach. And as I said, the rugal folds have a specific pattern. If we see here in the antrum, the rugal folds are very little less prominent when compared to the esophagus, and they are almost longitudinal. And if we draw a line, we have an inverted V-shaped kind of appearance, which helps us in differentiating antrum from the body. As already described by Dr. Raji, we have the Sievert's classification system, which divides the tumors of the gastroesophageal junction and which are close to the gastroesophageal junction into Sievert's class 1, 2, and 3. So the 1 are the tumors which are present 1 to 5 centimeters above the gastroesophageal junction. These are categorized under the esophageal cancers and staged accordingly. The tumors which are present 1 centimeter above the gastroesophageal junction up to 2 centimeters of the gastroesophageal junction are the Sievert's class 2, and they should also be categorized under the esophageal cancer. We have to look at the epicenter. And the tumors which are from 2 centimeters to the 5 centimeters, the previously, as it said, that the tumors up to 5 centimeters were under gastric cancers, but now since the change of the classification system, beyond 2 centimeters to 5 centimeters also is considered as part of a gastric cancer. We have to look at the epicenter of the tumor. So whatever tumors are present 1 centimeter above G, so the epicenter of the tumor, if it is below the 2 centimeters, then only we should grade and give protocol according to the gastric cancers, or else they will come under esophageal cancers. So the types of gastrectomy most commonly we receive for the cancers is the total gastrectomy specimen or the partial gastrectomy specimens. So the partial gastrectomy or the total gastrectomy depends upon the location of the tumor and to have the adequate adequate proximal and distal resection margins. So the partial gastrectomy can be proximal gastroesophagectomy, partial upper gastrectomy, or it can be a subtotal gastrectomy or a distal gastrectomy specimen. And then we have this terminology called as D1 gastrectomies and D2 gastrectomies. So these terminology is based upon the lymph node dissection, which is performed by the surgeon. So if we have the lymph node dissection in the D1 gastrectomies, what are included are the perigastric lymph nodes, which are present along the lesser curvature, and the perigastric lymph node along the greater curvature. And then we have a supracardial lymph nodes, which are present here, and those are the gastroesophageal junction lymph nodes. The lymph nodes present which are the supraduodenal lymph nodes present about gastroduodenal lymph nodes present at the distalmost part of the lesser curvature. And then we have the gastroepiploic lymph nodes, which are present below the pyloric region. And in the D2 gastrectomies, we have the lymph nodes which are dissected present around the celiac group of lymph nodes. Most of the time, we see them separately in a different containers and they are labeled. So in the D2 gastrectomy, we have the lymph nodes present along the arteries of the celiac arteries, which are the left gastric lymph nodes. We have the hepatic lymph nodes, gastroduodenal part of the lymph nodes, and the celiac axis group of lymph nodes. Even the splenic lymph nodes, which come along the splenic hilum, are also come under the D2 gastrectomy specimens. So this D1 and the D2 gastrectomy specimens, whatever lymph nodes are present, these are the first tier group of lymph nodes which the stomach cancer is draining into, and these are the second tier lymph nodes. And both of these lymph nodes come under the locoregional spread of the gastric cancer. So if these lymph nodes are involved, we stage it under the nodal staging. If the lymph nodes beyond these are involved, we consider it as a metastasis. So this is the specimen. If we look at this is the cardiac portion, which is along the gastroesophageal junction, the fundus, body, antrum, and beyond which is the pylorus. And this is the lesser omentum. So lesser omentum is just a fold of the serosa which has double folded on itself. So it includes two folds of serosa. The right edge of the lesser omentum below has a free margin, and above is attached to the porta hepatis, and the proximal small portion is also attached to the lower end of the esophagus. And this is the greater omentum, which is present along the greater curvature. The left end border of the greater omentum is free. It is not attached to any structure, and it just lies freely over the small folds of the stomach and the transverse colon. So the margins, whatever the free borders of the lesser omentum and the greater omentum are present, those should be taken as the radial margins. So when we receive the specimen, we should orient it so that the greater curvature is on the left side, lesser curvature is on the first side, and the greater curvature is on the right side. And then we can get ourselves to see the anterior surface of the stomach and whatever is behind is the posterior surface of the stomach. And then we have to go on to give the specimen dimensions. The dimensions should be recorded along the greater curvature, along the lesser curvature, the measurement of the lesser omentum, the greater omentum, and the esophageal length and the duodenal length, as well as the luminal diameter, if they are included along with the gastrectomy specimens. And for the esophagus specimen, if we have a part of esophagus, we better ink the outer margin because that will be the circumferential margin if the tumors are going into the esophagus. After that, we have to see if there are any findings present on the serosa. Like in case of perforations, we can see the perforation with the tumor directly extending onto the serosal surfaces. And if there are any exudates around the perforations, presence of adhesions, any deposits, or any other findings present along the serosal surface should be noted, nodules. And in case we don't see any kind of gross findings visualized, then you have to palpate the specimen. Just palpate along the stomach to see if you're finding any induration or any nodularity which would represent the tumor which is present inside the stomach. And after palpating the stomach, it is recommended to open the stomach along the greater curvature. But if you have any tumor which is present along the greater curvature, then so as not to disturb the stomach along the greater curvature, because if we disturb it, then the grading or the staging of the PT stage will be altered. So we should take a cut which is going along the arc of the tumor, but do not distort the tumor. If that is also not possible, then we can even open the stomach along the lesser curvature. Once it is opened, we fix it in the formalin. The ideal way to fix it is lay on the cork board and then pin it, but it can be difficult because of the storage issues. So we have to put it in a container large enough and add up to 10 volumes of the formalin for the fixation. After it is fixed and the mucosa is opened, we have to locate the presence of tumor. So once you see the tumor, we have to always give the location of the tumor, whether it is located in the cardia, fundus, body, antrum, or the pylorus, whether it's along the anterior wall or the posterior wall, or greater curvature or the lesser curvature. Following that, we have to measure the tumor in the 3 dimensions, which is transversely, superior, inferiorly, and also the depth. And then note the gross morphology of the tumor, whether it is a polypoid protruding mass or an ulcerating mass. And sometimes when you don't have a protruding or an ulcerating tumor mass, we also have to note at the rugosity of the stomach wall. So in many cases of the diffusely infiltrating stomach cancer, we don't see any mass-like structure. What we just see is the thickening of the stomach wall. So we should palpate to identify any induration of the wall of the stomach or any thickening of the rugal wall. And sometimes the only important clue is to look at the rugal folds, where you see the smoothening on the surface of the rugal folds, and also note the findings which are present in the adjacent stomach, like ulcers or congestions or any other morphology of the adjacent mucosal epithelium should also be recorded. So based upon a gross appearance of the stomach, we have this Borman's classification, who has classified into 4 types, whether it is a protruding polypoid type or a fungating mass with ulceration, or it can be a diffusely infiltrating mass where we don't see any apparent growth. It is just the loss of rugosity and smoothing of the wall, but the wall is thickened, or as an ulcerative growth. It is like a flat and ulcerated growth. We have 4 Borman types of grossing. Once we have located the tumor, we have to cut transversely to the tumor so that we expose the tumor from the mucosa till the serosa. So once we cut the tumor, so this is a picture taken from the Tata manual. So we have to lay down the specimens. So this is the adjacent mucosal epithelium and this is the tumor. So cutting like this provides us with the most important information of the depth of the tumor invasion, because the depth of the tumor invasion is very, very important for the staging of the tumor. So if we have a tumor up to the lamina propria, above the muscularis mucosa, it comes under T1A. And if it goes into the submucosa beyond the muscularis and not infiltrating into the muscularis propria, then we call it to T1B. And once it enters the muscularis, it is T2. And if it crosses the muscularis propria and enters into the subserosal fat, it is T3. And we have to call it T4 only once it reaches the serosal margin. That is the serosal lining, whichever is there, should be breached to call it a T4 stage. And T4B involves if it is infiltrating into the adjacent structures like the bed of the pancreas or the kidney present on the posterior aspect of the stomach or the transverse colon in the stomach, and sometimes it also infiltrates into the left lobe of the pancreas. So presence of direct extension into adjacent structure comes under T4B category. So coming to the other things which are very important in the grossing after the grossing of the tumor is the margin assessment. So we have three margins for the gastrectomy specimen. One is the proximal margin, which is present proximally whatever the sutured end is there, or the in case of gastroesophageal resection, then the end of the esophagus should be taken as the proximal margin. It is, if the tumor is very close to the margins, it is always better to take a longitudinal section so we can assess the distance of the margin with the tumor microscopically. If the tumor is far from the resection margins, we can take a transverse section. And the other margin is similarly the distal margin, and the radial margins are the omental margins, which are the greater omental and the lesser omental margins. So if the tumor is infiltrating through the serosa on the anterior or the posterior wall, they don't come under the radial or the circumferential margins. It only alters the T staging. And after sampling the margins, we have to look at the adjacent mucosa and always sample the adjacent mucosa and the gastroesophageal junction to look at the background pathologies. And then we have to sample the lymph nodes. Like, as I already said, you sample the lymph nodes along the greater curvature and the lesser curvature and along the supracardiac region above and below the pylorus. And following that, if you have to look if there are any peritoneal nodules. So the presence of peritoneal nodules indicate a distant metastasis. So the sections to be submitted for microscopic examination are the tumor sections with serosa, adjacent normal mucosa, the margins, adjacent gastric mucosa, and the lymph nodes. The reporting format where you describe the procedure of specimen resection done, the tumor type, the site of the tumor, histological type, and the extent of the tumor. That is the PT staging up to the level where the tumor is infiltrating the wall of the stomach. We have to give the description of the tumor and also never forget the background stages which are present in the mucosa, which will tell us the pre-neoplastic conditions like metaplasia, any dysplasia, atrophy, and H. pylori in the background stomach, the status of the margins, presence of lymphovascular emboli and perineural invasion, which are one of the prognostic parameters for assessing the gastrectomy specimen, and the number of lymph node involvement and site of the lymph nodes with tumor involvement. And following that, we have to do the AJCC staging. So if we have more than one focus of tumor, we have to use this TNM descriptor. Like before keeping the P, T, and M, we have to give it M if there are multiple foci of tumors, Y if the tumor is a post-treatment, R if it is a recurrent tumor, and A if we have found the tumor in the autopsy. In case of autopsy, we find a gastric tumor, and that should be described as A. So coming to the AJCC tumor, as I have already described, the T staging depends upon the level of the tumor invasion into the wall of the stomach, which is lamina propria, submucosa, muscularis mucosa, subserosal tissue, the visceral peritoneum, and directly involvement into the adjacent organs. And during the staging of the PT, it is important to see that if the tumor is extending from the wall of the stomach into the greater or the lesser omentum or into the ligaments of the gastrocolic or gastrohepatic, it is still T3 because they are present in the subserosal fat. Unless the serosa is breached, we should not call it T4. Once the serosa is breached, then only we have to go under T4 staging. And if the tumor is extending into the adjacent organs along the tubular structures, like if it is going along the muscular or the submucosal layer into the esophagus proximally or the duodenum distally, we should not call it a T4. It is not the direct extension of the tumor because it is extending intramurally. It's coming to the lymph node staging. Based upon the number of the regional lymph nodes involved, we have the different nodal staging. The regional lymph nodes are based on the D1 or the D2 gastrectomies. Based on the number, we have N1 for 1 to 2 lymph node involvement, N2 for 3 to 6 lymph node involvement, N3A and B for 17 to 15 and more than 16 lymph nodes involved. Want to ideally stage the tumor and say that 16 lymph nodes are involved. That means we should at least sample 16 lymph nodes, and ideally 30 or more is desirable, but we know the challenges sometimes we don't find. So it is recommended that we sample at least 16 lymph nodes for adequate staging of the tumor. And if we have a metastatic carcinoma deposits, sometimes we see that around the muscularis mucosa and within the fat, there are just tumor deposits present. And with no morphology of lymph node around the tumor, like we don't even see the capsule, we don't see the lymphoid tissue, no vascular or neural structures, then we should call it a, we should also take that as a lymph node deposit and not as a tumor deposit. We should also count it as a lymph node deposit. If we have a vascular and neural structure, then we should be careful that it is not a lymphatic emboli or a perineural invasion. If all these are not present, then the vessels or nerves are not present, we should also count it as a lymph node. So coming to the lymph node staging, as I already said, D1 and D2 are the regional lymph nodes. The retropancreatic, pancreatico-duodenal, peripancreatic, supramesenteric, the middle colic, para-aortic, and other group of lymph nodes are all non-regional lymph nodes. That is, they should be staged under the M category as distant metastasis. So based on the presence or absence of distant metastasis, which we have assessed pathologically in the specimen, we call it M0 or M1, which are the direct extension into adjacent. If there is a direct extension from the serosa into liver, colon, pancreas, or the diaphragm, it is not a distant metastasis. It is a T4B stage. If we have nodules in the peritoneum and even presence of abnormal malignant cells in the peritoneal cytology is also taken as metastasis category of M1. Thank you. So I think most of the things I have covered, except for the post radiotherapy staging or the assessment of the cancer. So we don't have any staging system, proposed grading system, but in CAP protocol, we have the tumor residual tumor categories, where we have 3 categories, whether we have the viable cells present or not, single cells or small cluster of cells. And the second category, where we have a tumor regression, but it is a partial regression, there is no complete regression. And then we have third one, where we have complete regression. Based on that, we can categorize the tumor regression scoring system. Thank you. If you have any questions, I'll be happy to take the questions.
I think there is one, Gitanjali, one question in the chat box.
Yes, ma'am.
The last one, ma'am.
Can the question?
Yeah, it's to repeat the radial resection margins.
So the radial resection margins are the ones which are present along the lesser omentum and the greater omentum. So for radial resection margin, they should be lying freely in the peritoneum. So the lesser omental margin, which is leftmost part, or the one, it is just the 2 folds of the serosa which are covering upon itself. So whatever is the edge of the serosal lining of the omentum are the radial resection margin. If the ones which are present along the anterior and posterior wall, those serosal margins are not taken as radial resection margin. They're important for the tumor staging. If there is a breach in the serosa of the anterior or the posterior wall, it is T4. It comes under the T4 category. But for the resection margins, we have to consider the lesser omental and the greater omental margins. So the omental margins are the only radial resection margins in a gastrectomy specimen.
There is one more again, I think. You can see it or you can't see it?
No, ma'am, it is taking some time to open.
Okay. So clinically, say word 2, but on gross, E junction epicenter is less than 2 centimeter and state says esophageal cancer. Clinician call it stomach cancer, but B state says esophageal cancer. How do we explain it?
So it is always, in pathology, we should always discuss with the clinical person. So the clinicians must have staged it according to the radiology. So we should correlate radiology with our pathological findings. So look at the size of the tumor, whatever is there, and just assess in relation to the gastroesophageal junction. So as I said, we can see that mark of the whitish mucosa and pinkish mucosa at the gastric esophageal junction. Just take 1 point there and then see the total length of the tumor. So within the widest dimension of the tumor, we take the center. So from this center to the center of the gastroesophageal junction, we have to take the distance of the tumor. So it's always better or call up the surgeon. Sometimes even the surgeons are kind enough to come and have a look at specimens so that we can accurately say where the tumor it is. So most of the time clinically it is assessed based on radiology. So we have to have a clinical and pathological correlation in cases of discrepancies.
Also, I think I just want to add at this particular point, also sampling from the adjoining relatively uninvolved mucosa will help you to decide. Especially if it is esophageal origin, then you have to take the lower end of the esophagus where it may show something else more than just the normal stratified squamous lining. And if it is of gastric origin, definitely the gastric mucosa, which is not the tumorous component, would definitely show changes of chronic gastritis, atrophic gastritis. All those additional findings will help you to narrow down your possibility of the whether to label it as a esophageal cancer or whether it is to label it as gastric cancer. So I think additional sections from the surrounding uninvolved mucosas are very, very important. So one needs to really have all the time adequate sampling from those areas as well. Any more questions from the audience?
And there, one I have seen that if there is inflammation present along the serosa, then whether you should consider it breach or not. So if we have to look at the breach of the lining of the serosa, and if we have inflammation, we can do some elastic stain also, which also helps us to identify if we have the breach in the serosal lining to identify the staging, whether the serosal breach is present or not.
Yeah, the EDG stain is very, very helpful. Similarly for pleural involvement also, whether it's a metastatic tumor or whether it's arising from the lung parenchyma. Okay, anything else surrounding inflammation? That's all. Anything? Oh, there's more. One more coming up. You can see it.
Is there any ideal way to sample the adjacent mucosa? So if I go from proximal to distal to sample the adjacent mucosa, if we consider the pre-neoplastic conditions which we have in mind, the most important thing, one is the Barrett's esophagus, which also helps us to decide the tumor. So it's all we have always have to sample the gastroesophageal junction, and we have to sample the stomach and the body of the stomach, the body and the antrum of the stomach both, because again, if we go into the pathogenesis of the cancers, one is to identify the atrophy of the tumor, the atrophy background tumor, background stomach atrophy, which is one of the stages in the pre-neoplastic conditions. We have to take from the body of the stomach, and to assess the chronic gastritis and any H. pylori associated pathogenesis, we have also to sample the antrum of the stomach. So one, we have to take the mucosa just adjacent to tumor.
The question is ideal way. How, from where to take those samples? The question is ideal way of sampling. And so I think what I want to say is it's very important for us as a morphologist to understand what is the normal pattern of mucosal folds. both in the stomach, maybe esophagus also, we have to know the color. The color is very important. Definitely in the stomach, we have to know what is normal mucosal folds looks like. There is no granularity, they are velvety, very fine mucosal folds, very uniform all over. So one has to look the fold pattern. There can be some nodularity in the fold pattern, some granularity in the fold pattern, away or adjacent to the site of whatever the primary lesion. Those are the sites from where you have to target your additional sections.
Yes.
Okay, any more questions? Okay, there's some more coming up.
If the tumor, I couldn't see it completely. If tumor is present in omentum, can you read out the question?
Yeah, if the tumor deposits is present in omentum without capsule, partially capsular bridge, she is meaning, or he is meaning, how can we include them in TMN staging?
So in the AJCC, they have said that if you have any tumor in the omentum, even if you don't see any capsule or the lymphoid tissue, we calculate them as the lymph nodes. And it is important that it is not present in relation with any vascular structure or any nerve-like structure, because that would otherwise indicate a lymphatic or a vascular embolus or a neural invasion. So if we have any tumor deposit without capsule, lymphoid tissue, vascular or neural, we take it as a lymph node.
There is one more question, I think, after that. Can you see it?
No,
Do you separately give the nodes according to the region?
Yes. So we have to give nodes according to the region. And if we are sampling the omentum where we see the lymph nodes, those are taken as the perigastric lymph nodes. So we better sample the tumors according to region. So those regions are important to identify the lymph nodes which are present around the stomach. But while in staging, it's just the number of lymph nodes which are important rather than the site of lymph nodes. The importance come in case of site when it is present around the pancreas. That is retropancreatic, peripancreatic, pancreatic or duodenal lymph nodes. All those comes under distant metastasis. So in that case, the site becomes more important. So here, knowing the stint so that you can sample in that location where you can find adequate number of lymph nodes.
There is one more. Please also tell how to sample nodes.
So in sampling of the nodes should always be done after you have taken the sections from tumor so that the serosa margins or the depth of the margins are not altered because of lymph node sampling. Once the tumor sections are adequately taken, then you have to do a palpation method step by step. Once you palpate it and you find any the firm or nodularity, then with scissor, you better cut it nicely with a little bit of fat around it. Just palpate it and do like a cherry picking kind of thing with proper dissection so that we can also see the pericapsular spread. We have to separate out the fat around the lymph node and take it. We have to press our fingers on the board, like on the crossing board, just press it along the fat to feel for any firmness of the like a lymph node.
Yeah, I think lymph nodes are all the time feel better if one is very particular after the specimen gets fixed. And I think there are techniques where you can dissolve the fat in the surrounding areas, and that is another method, but that is quite time consuming, which possibly is not very practical for day-to-day routine sampling and grossing. There are various techniques are there, but I think the best is if one is really very particular, even not wanting to miss the small ones, keep the specimen for fixation overnight and do the grossing the next day. That's the best way of not missing or not like missampling a fat lobule as lymph node or a lymph node being missing as a fat nodular area. So I think the fixed specimen is the best way to do and it should be palpated against a flat and hard surface. Spread out the fat and then palpate with your palm and with tips of your fingers. That's the best way. If one does it roughly, I think that picking it up and do it, then you are going to miss many lymph nodes. So spread it out against a flat surface and then palpate it properly. And there is one more question, I think. So we should not strip the fat. Gitanjali, there's one more question.
You can strip the fat if there is a lot of fat where you have to take out step by step in all the areas if you want to palpate, but it should be done strictly after the tumor is sampled.
If you stripped out the fat, then you're going to lose out all lymph nodes. So don't strip it. Keep it with a specimen. You don't want to lose out the surrounding lymph nodes in the fat. Anything else? Any more questions? I think that's all. Pasale Gitanjali?
Yes, ma'am.
Bharati ji is saying thank you. Thank you very much to you for asking so many questions. But please keep the fat intact, huh? Don't strip it. Okay. So Gitanjali, thank you very much for the excellent presentation. And I think now we go to the next session. I think we are just sticking on to time today. I think very different from yesterday. Yesterday was a mess. Okay, the next session is
Thank you
on
so much.
biopsy statement for intestinal pseudo obstruction. The speaker is none other than Professor Usha Kinney, which we all know about her, who has been working on these conditions for many, many years, and she has had a lot of good publications and experience. And so I'm very grateful to her to have accepted my request. Dr. Usha, this is her, I think, biodata, and she is also heading the department of pathology and many other things along with that in St. John's Medical College, but I think it's something translational research lab for gut motility disorder. This is based in St. John's Medical College. And so it's a big thing, and she's been really having a lot of work in this and also collaborative works from multinational collaborative works. Dr. Usha, I thank you for accepting the invitations. And so the stage is all yours.
Oh, thank you, Dr. Kim. Wonderful to see you all. Very good morning to all of you. It's my pleasure. I bring you greetings from Bangalore and from our lab, the Translational Research Lab for the Gut Motility Disorders. We have been going through from yesterday's talks and today's talks, there has been a pathology basically in the lumen, in the wall, and it is obvious to the eyes, right? You see the mucosa, which is ulcerated, there's a tumor, there's a proliferative lesion, etc. But here we have a lesion. Say, let's look at a baby. I'll take a baby in consideration. Here is the colon. And for us, I know it looks normal. There's also another structure here, the normal, which I say abnormal. Now, is there any difference between the two? The abnormal portion is this, which is markedly distended in the upper portion, and it is narrowed or maybe not so significant in the lower part. Now, for many who look at this condition, this uppermost portion, which is markedly dilated, is very striking. And that is where one has to think, where has what has gone wrong? So this has been a puzzle to many, and especially the postgraduates who enter the field of pathology, they start wondering, what am I looking at this colon for? So this is a small clipping from Harald Hirschsprung's, on whom this disease has been named. He presented the autopsy data on 2 kids. And his words are very interesting. He says, as you will see, it is a colon, but a colon of such a size that it will no doubt surprise you to learn that it comes from a child. That means to say the colon that is resected and that he has seen on the autopsy must have been huge. And for someone, it looks like as it belongs to an adult. but he says it's only 11 months old when it died. And when the abdominal cavity was opened, he saw a couple of extremely dilated intestines emerged, and that was the sigmoid, and the other part of intestine turned out to be somewhat dilated. But he also notices that rectum was not dilated. And he very specifically says they indeed subject to no obstruction. So there was no obstruction in the rectum, but still the proximal part of the colon was so markedly dilated. So his attention was drawn to the markedly dilated portion of the colon. And this is what he presented for the first time at the annual Pediatric Society meeting at Berlin in 1886. But he strangely, or whatever you say, he didn't attribute the cause or the pathology to the spastic portion of the rectum. Yet, so now we have this colon, which we know that if the distal portion is the most often affected, because we know that this is a disease of Hirschsprung's that we are talking about, which is pseudo obstruction, because there is no luminal pathology. So if somebody is trying to look, there is no luminal pathology at all. And then as the spasm goes on, the lumen gets dilated, it narrowed, and that results further to pressure effects. So, feces not being able to pass down, so it undergoes dilatation. So the proximal colon is dilated. So when we look at pathology, we are always look at what is so big, what is dilate. Oh, there must be the pathology there, but it's the other way around here. So this whole gross, whatever findings was given a name of congenital megacolon in 1894 by Meyer. Though Herold described in 1886, he called it dilated colon, yet the name so-called megacolon to the normal proximal colon, which is markedly dilated, was so called. But one should always know the pathology is lower down in the lower aspect of the rectum, which is spasmodic and is narrowed. So the significance of spasmodic colon was attributed to aganglionosis, and it happened only in 1948. So until then, all the pathology was focused on to the dilated megacolon. So we have it right here. And this distended colon is seen as dilated or palpable bowel loops in the child. So the patient presents with constipation and with distended colon as palpable bowel loops, which are even seen on gross examination, but the spastic rectum goes unnoticed. And when that spastic rectum is with a portion of the proximal colon is resected out and opened out, you see that there's absolutely no pathology in the lumen, not even in the mucosa as you see, but the entire thing is because of the aganglionosis causing the spastic colon, spastic rectum, because of the increased acetylcholinesterase, and that the bowel totally forgets how to relax. So that is why the child is not able to relax the sphincter and pass the feces down. So the dilated bowel, the resected specimen for this patient, we know that surgery is the only cure at the moment for this disease. And the specimen may be as small or as big as you see it here, or it could be so huge as this. This is the case of a 22-year-old male from a 10th hospital in China. They have claimed this to be the largest megacolon ever described in the history. And so much so, it weighed 13 kgs of feces loaded in this bowel, and it was spread out on the floor. So it shows that a person can tolerate constipation with and treat himself with enemas, and yet have this disease and present later on in life as an adult. So it can be diagnosed as early as a 1 day, the first on the date is born or the second day, or it could be in an adult of 22 years, or still we have had in a 54-year-old male who has given up taking enemas. He says, now let me go for surgery. So that is the beauty of Hirschsprung's. Now coming to the grossing of biopsies. No, always that I say that we will not receive any biopsies without a completely filled request form. So there is no better word that I can say, that a biopsy which lands upon the table without a request form is definitely refused. It is not accepted. And I would accept a pro forma, which you can devise on your own. What is the data that you want with reference to your patient? And the operative details, the radiological details, etc. But always remember to have a colon map to identify from where the biopsies are taken. So I totally insist that this needs to be filled up and then sent across. Now coming to what are the biopsies that one could send in case of Hirschsprung's. So I'm considering Hirschsprung's as a prototype of any pseudo-obstruction. Pseudo-obstruction is, yes, a condition where you find that there is no obvious gross pathology in the resected colon, and gives you something dilated, and that there is a pathology microscopically, but no obvious pathology on gross. So what are the biopsies so one can receive? If this is a longitudinal section taken right through the pelvis. Now the first is the rectal biopsy, which is taken lower down 2 centimeters above the dentate line. The second are the leveling biopsies, which could be taken depending on where the surgeon feels that is necessary. And the third is the donut. Now, let me explain to you a few things which is very, very important anatomically and that we must be aware of. So this is the rectum, the whole length of the rectum. It takes a turn to become the sigmoid. And at this point also, you have the peritoneum which lines the space which is behind the bladder, anterior wall of the rectum. And this is known as the peritoneal reflection on the rectum. So this is also called by the surgeon as the PR. So peritoneal reflection. So this area can accessed only through transabdominally, either through a laparoscope, most often by a laparoscope, whereas the rectal biopsy has to be per anally. It has to be taken, visualized, dentate line, visualized and taken. So these are things which are done by the surgeon alone. We do not attempt to do it. And this leveling biopsy, the first one, comes from the peritoneal reflection because it's the most distal portion of the rectum that can be accessed per abdominally. The subsequent ones could be from the sigmoid, which could be distal sigmoid, mid-sigmoid, proximal sigmoid, so as we go higher up. And when the resection is done, we would get what is known as the donut. So we will expand on each one of them as we go by. So the journey of the biopsy all depends upon which route do I take. That's what the biopsy says. Is it for fast reporting alone? Then that means to say the surgeon is proceeding thereafter for a surgery called as primary pull-through. So he's doing the first rectal biopsy and then he does leveling biopsy. So what is the purpose of the leveling biopsy as we see here? This is because if there is aganglionosis of the rectum, one wants to know how far is of the segment is aganglionic, because A ganglionic segment is the pathological area. So we do not want that to be included. We want that to be resected. So that is assessed by a representation of the circumference by a leveling biopsy. Okay, so the fast reporting you wanted, wherein the baby is on the table, it is for a primary pull-through surgery, where following the rectal biopsy, one goes across to do leveling biopsies, and after that, a complete resection of the pull-through, that is known as the pull-through, to get the ganglionated segment, which is brought down to the anal and anastomost. And the next is, what kind of biopsy is it? So it could be mucosal, it could be leveling, it could be donut, or the resected specimen. So we will concentrate on these 4 kinds of biopsies. And the fast reporting, we leave it aside, but I will tell you how you can handle these biopsies as we go by. So the biopsies could be full thickness, then it is of no problem because it's really big and it has all the layers and you know how to orient it. It's like any other biopsy. But what we get from the rectum and from a child, and especially from a neonate, and if it is mucosal, this is all that we get to see. And it would be more or less a single biopsy. And on this, the crux of the situation is the proper orientation of this biopsy, so that you have the mucosa on one side, below which you have submucosa. In spite of that, yet we call this as mucosal. We do not call it mucosa or submucosal biopsy. We say mucosal, expecting that it should have submucosa, and all surgeons know that they have to give us a submucosa along with the surface mucosa. And then comes the seromuscular biopsy, which is taken from the serosal side transabdominally through probably a laparoscopic. And that has only muscle layer and no mucosa. So the seromuscular biopsy sample the myenteric plexus, whereas the mucosal biopsy sample the submucosal plexus. In submucosal plexus, the ganglion cells are few and far apart, whereas seromuscular have ganglion cells well spaced out, and this is easier to report on. But the expertise lies on reporting the mucosal biopsies. Now, what do we say that this mucosal biopsy is ideal? It should be bigger than 2 millimeters. So we are happy if we get something like 2 millimeters in a neonatal, and from a child of that size. So anything 3, 4, 5, and 6 is luxury. Okay, and it needs to be taken 2 centimeters above the dentate line. So this is the dentate line, and the dentate line is the junction of the transitional epithelium with the rectal mucosa, which is columna. It is not the squamous with the transitional. So you want your biopsy at this point, and this is what you need to notice under microscopy. But on gross, you will not be able to make out anything, whether it is from below or above the dentate line on gross. But if you have anal mucosa, it is quite obvious because it will look whitish in color, so much so sometimes it may even be pigmented. Now, how do we receive the biopsies? So what instructions would you give the surgeon how to send these biopsies? So let us say that this is the biopsy. It is fresh. It has just been taken out from the child. So it needs to be covered in a saline soaked gauze. So keeping it wet and sort of moist. And then it gets wrapped in a plastic cover, maybe a Ziploc bag. And that goes into a box, preferably a thermocol box. And that goes into ice cubes. So this is the way we would expect if you want mucosal biopsies to be processed as for frozen. Number 1, Number two is this mucosal biopsy on frozen. As I've told you, submucosal plexus are very difficult to search and get to search for ganglion cells. So what do we need? We need to have auxiliary techniques like acetylcholinesterase enzyme. So because it's an enzyme histochemistry, we need to preserve the enzyme, and hence it has to come sent in fresh and not put in formalin. Formalin denatures the enzyme and cannot be assessed for histochemistry. So if the specimen comes in formalin, it can be processed like any other endoscopic biopsy, which I'll deal with it later on. But if you are receiving it for frozen, you're doing a histochemistry. Yes, this is the way it needs to. Remember, acetylcholinesterase has to be sent, the tissue for acetyl has to be sent fresh and not in formalin. Many times surgeon says, please do acetylcholinesterase ACHE, but they'll put the sample in formalin, but it's all gone. You can do only paraffin processing, look at it microscopy, and probably do immunohistochemistry. Now, would you recommend tissues to be sent this way? It is in a bottle. They are labeled 1, 2, 3, 4, 5, okay, and they are in ice cubes. So would you prefer that? Definitely not. This is not the way to send, because there is the glass acts as a barrier for keeping the tissue cold. It takes a long time. So this is how it is received in a thermocol box, because this is easy to get, economical, procure. Otherwise, you can use any ice box for that matter. These are the few instruments that you need. You definitely need a magnifying glass, and you need a forceps which doesn't crush the tissue. So it comes with the label. The tissue is here in a saline soap, and this is how the tissue with the tag. It has a silk suture in it to, because that's how they take a biopsy, and with the tag, they send it to you so that it's easier for you to handle, so that you do not crush it at any moment of time. And you could magnify it to look at which is the rough surface, which is the smooth surface. Any hemorrhagic area is the submucosal side, and the rough surface or not so very shiny is the mucosa, which has a velvety surface. So as we were listening to the talks yesterday, it has to be embedded perpendicular to the cutting surface of the thing. So this is the tag, the suture, which we cut it, slide this biopsy down it, and put it on the, this is for the, these are the chucks for frozen section, but the same procedure holds good if you are doing the same for paraffin. Now, as I do, I want to explain to you, this is from a 3-day-old. This is the size of the biopsy one could have, and this is the medium on which it is, what you say, it is to be embedded. So the orientation is the crux of the whole thing. So all depends on how you orient. And that is why we as pathologists, when we report, when we receive it, treat your technicians, teach your postgraduates. So all of you learn how best to orient at 90 degrees to the cutting plane. So this is how it would look when you put it on the chuck. And this is what an ideal mucosal biopsy is for Hirschsprung's disease. So it has mucosa and sufficient amount of submucosa, which is not hemorrhagic. And this is the full thickness, which I need not explain, which is very simple. So this is a 2 millimeters. This is the frozen section from a 2 millimeter size biopsy. One could see artifacts, but still it is perfectly all right for reporting. Now coming to the leveling biopsy. This is the colon map. Unlike the biopsies that we receive from colon for various other lesions, here we look at it in the opposite way. That means to say the first biopsy is always rectum. Do you know why? This is because the rectum is the most distal portion of the colon, and that is the one which can be, the ganglion cells may not migrate down to innervate it. And that is why if the child has Hirschsprung's, this is the first biopsy to show you that it is ganglionic or aganglionic. Then comes the peritoneal reflection. I showed you the importance of PR. And subsequently lower sigmoid or distal sigmoid, upper sigmoid, and descending colon transfers, etc., etc. So you don't go, most often I've seen people numbering it from, say, now this is cecum, so this is number 1, transverse is 2, 3, 4. It is not. It has to start from rectum because you want to hit at the pathology at the first go. Now, for example, this is what I got a request the other day. So this is the rectum, this is mark 3. This is biopsy from sigmoid colon. This container was marked 1, whereas colostomy site was marked 2. So is that correct? No, this is wrong. It has to be that this should have been number 1, this is number 2, and this is number 3. So if we keep this and look at the biopsies in that fashion, I think our mindset and reporting goes like mathematics. And if you have many leveling biopsies, so say if I get 5 leveling biopsies, do you mean I'll have 5 blocks and 5 slides? No, I'll cut it short to 1 and I'll color them. This is how I would color from green, yellow, blue, orange, and purple. So this is the way I would use my coloring inks, and that's very, very useful. And if they are so small as this, best is to go for agar embedding. And this agar embedding, I'll come to that. So these are the instruments, simple ones that you would need. This is the chuck. So you can color them, cut frozens all together at one shot, or you can process them thereafter for paraffin like this. So you can economize on cutting. You can economize on the number of blocks. So make life simple, as simple, and save on time and money and as well as labor. So we brought out this on a paper which is titled Improvised Double Embedding Technique of Minute Biopsies, a mega boon to histopath lab. So one could interested can go to this article which came up in 2015. So the handling of biopsies on the frozen is the most crucial. How do you embed them is equally important. Now, what I want to say is this. So after you embed and after you cut, this is how you cut the frozens. So instead of taking for one biopsy 20 minutes, here 5 biopsies at one shot, you can finish in 20 minutes. So, you know, you can cut down on the anesthesia time, wait period for the surgeon. They are very happy. And so all this is possible if we have the expertise, we have the passion for it, and we are ready to do it. You know, that is something that must come from us, from our heart. Now, and just to go to the leveling biopsies. So how do we look at the leveling biopsies? Because it is completely made up of muscle, the muscle contracts, and it takes the shape of a C. And this is the embedding surface. So when we embed as a C, you will have outermost layer and the inner layer of the muscle. In between, you will have the multiplexus. And these are the serial of biopsies that one can have on a slide. And this is what you will see under the microscope. So it's very simple, provided you know how to embed them. So in the initial stages, I want the pathologist, you know, to do it so that you know what you're going to look for, teach the technician, and so they also learn the technique. And one could also do an acetylcholinesterase. I'm not showing this. Acetylcholinesterase purely is done for rectal mucosal biopsies, but I never recommend that for a full thickness, never for a seromuscular. But I'm just showing it to you how to identify ganglions and see this, how they are so strongly positive and the orientation. I just wanted to show you this night. Now, why are we doing leveling biopsies? I told you, yes, we are doing it to assess the length of aganglionosis. So is that important? Yes, for a surgeon, because he wants to know how much of the colon he has to resect. he might get guided by radiology. But one thing, radiology doesn't go hand in hand with histology all the time. So the surgeon is always on a, he's worried. He knows that he can't take things lightly. So he prefers to do leveling biopsy as he sees on the table. So now let us look at what is its implication. So this implication is to type Hirschsprungs. As for example, this one, if it involves only the lowermost, we call it as ultra short segment. If we have the most distal part, we say short segment, which is ganglionic till rectum. But if it involves even the sigmoid, it becomes the garden variety, which is rectosigmoid. If it crosses the splenic flexure, it becomes the long segment. If it involves the entire colon and up to 30 centimeters of the distal ileum, it becomes total colonic aganglionosis. And if the whole intestine, including the small as well as the stomachs, it is called as a total gut aching, which is extremely rare and it is incompatible with life. So these are the varieties, and this is a must to phenotype these lesions because of the prognosis. The long and the total colonic have a bad prognosis in that diagnosis is difficult for the surgeon. So it is diagnosed most often at the 3rd and the 4th level, and the resection that is involved is tremendous. So the child has to compromise with a lot of colon in these conditions. So we'll go to the resected specimen, the pull-through. How do we go about? So what is pull-through procedure is the final stage after the diagnosis is made with the rectal biopsies, leveling biopsies to say the aganglionosis. Then the surgeon decides how much is he going to resect, by what method. The first is the Swenson, wherein the red shows the the portion of the rectum which needs to be anastomosed with the distal part of the anal region. This is the area of anastomosis. So the entire aganglionic is taken away. The most common, widely practiced is the Duhamel, where the portion of the aganglionic segment is left behind anteriorly, and you have the ganglionic segment from the proximal being brought down and anastomosed. This is the Duhamel. And of course is the Sovis, which is practiced in a place where they have support from the pathology for the rectal biopsies, for the leveling and everything at one stage. So Sovis is most often done preferably in the first stage when it is called primary pull-through, or in the second stage as the, after the diagnosis of on the rectal biopsy. So here the ganglionic slips down and is broadened, whereas the aganglionic is taken away. I'll show you the specimens as we go by. So this is the mapping biopsies, leveling biopsies that come in, which will help us to label till what length is the aganglionosis. Then resection is done. So this resected dip has a distal narrowed end, which is the spastic end, as I've shown you earlier. This is the dilated proximal portion. So this is always proximal, this is always distal, and it is opened out vertically this way. And subsequently bits are taken and we do this. So I'll explain to you in the next in detail. So a longitudinal opening of the specimen along in the anti-mesenteric area. So we don't use the mesenteric area for any of the bits when it comes to pseudo-obstruction, because that is the area where the blood vessels and the nerves enter. So you will get false readings. So we have to do anti-mesenteric. So this is the most distal surgical margin. This is the proximal surgical margin. Now let's look at the diagram. So this is the distal. So I told you we start with this blocking as A. This is the shape of the tissue. And one long strip is taken this way and subsequently cut at every 2 centimeters, hoping that this length is usually not more than 10. And there's a way that we economize here, that we put 1, 2, 3 bits all in one block, that will be B. The subsequent 1, 2, 3 will be in C. And each one of its, the distal ends are inked as green, yellow, and blue. So green, yellow, and blue. So I know what you are looking at. And this picture has to be drawn on the reporting on your request form in the crossing, page, so that we know where exactly bits are taken. This is a must, as we expect a duly completed request from the surgeon. This is picture drawing is expected from the person who grosses. If it is not done, I do not report on these biopsies at all, because A could be here, D could be here. I don't want any mess, wrong interpretation. And these are, say, for example, this is A, it is shown here. These bits of B are here. This is how we take them, and the last. So 1, 2, 3 plus 3, 6, 7, 8 bits have all been covered in 4 blocks. And this is how we get the sections and we study them. Now, here is a picture that I just got it on the web, and they say that this is how they block. This is also very practical and can be done. So horizontally taking the bits at every 2 to 3 centimeters. This is to see how far is aganglionosis and in what direction are your ganglion cells migrating down from the proximal to the distal. But I don't agree with the numbering. Here, the numbering has started from A2, A1, of course, I think it's covered. So they've started from the proximal and come down to A11 at the most distal. But it is not correct, because the pathology is here, and I would prefer it to label it as from ABCD upwards. This is the way I would expect, and it is most convenient, most comfortable, and interpretable for us as pathologists. Now we come to donut. So what does donut mean? For that, we need to understand what is the importance of the donut. So here we have the healthy, or the, say, ganglionated colon. Here we have the portion of the anus, and this is the affected part of the rectum, say aganglionic. Now the surgeon is going to resect that out. So he has to bring this down and anostomose here. So, but he wants to make sure that this part is well innervated. That means to say, he wants to make sure that ganglion cells have migrated and innervated the entire circumference of the colon. And that is what we call it. He sends one round circumference as the donut. And we need to see how well is this innervated. So this picture I've shown you how ganglion cells migrate. They don't migrate at one go like a parrot. No, one is ahead of the other. There's always in a competition. So this is called as the leading edge, whereas this ganglion cell is taking still time to reach this part. So this part is aganglionic, this is ganglionic. If we anostomose this, the child is not going to do well at all. And we say that this area is called as the transition zone. So this assessment of the donut of the most distal portion of the anostomosing segment is known as the donut. And it is assessed as 4 quadrants. If it is very big, or it can be processed as one single fragment, piece of tissue, or it could be cut into 4 if it is bigger, and labeled accordingly. So what is this transition zone? It is this area, the junction of the aganglionic with the ganglionic. And this is the area which is crucial, because this is the area where the normal is merging with the abnormal, and the surgeon does not want any of this anastomosis at this transition zone. The bowel is not going to move or functionally will be abnormal if any anastomosis is done at the transitional level. And this is how we pick it up at the donut. Now we have the Sovis I was saying. All we dealt was duhamal. This is Sovis, where we have the distal mucosal tube. Because it's done transanally, this part of the muscle is left behind as a cuff for the rest of the ganglionic segment, which is brought down as shown in the picture earlier. So they will have long mucosal tubes, no muscle here, then comes like a full thickness. So we gross it just like the way we gross any duhamal, what I have shown you, taking one surgical margin here called as A, then subsequently BCD, and this would be the donut. For the, not the donut, this would be the margin. But this I wouldn't consider as the donut because the surgeon would have already sent the donut for 4-quadrant assay. So that for me, that donut is the most distal margin and not this. Now we come to stoma biopsies. So after all the surgery is done, the stoma which is done to relieve the obstruction has to be closed. So it could take time after all that. So the type of stomas are here is the end stoma. This is where the intestine colon is brought to the abdomen and opened out to let out the contents. Or it could be a loop. Should I cut? Am I audible? Hello? Yeah, I'll just take a few minutes. So this is the loop colostomy and the other one is the end loop. So either ways we want to know as this part is connected to the rest of the intestine, we want to know how well is innervated. This is very important and one vertical bit. Subsequently, it's done for the others. So the biopsies in HD are rectal biopsies, leveling biopsies. We have the donut, we have the stoma biopsies, and we have the resected specimens. So the surgeries that we would be told is it is a 3-stage or a 2-stage or a 1-stage. So if it's 3-day stage is first rectal followed by a biopsy, leveling biopsies, then pull through, then stoma closure. Or it is rectal biopsy, leveling and pull through. Or it could be the primary pull through or the first stage or the only stage where one does rectal biopsy, leveling, pull through all at one time at one go. So this is the last slide of mine. I just want to know your comments on this. So this is a duhamal and this pathologist wishes to label this saying this is A, B, C, D down up to K. He's going to take beds transversely. Is this right? It is not, because it should have been A. This is the abnormal or the pathology part. This is where the surgeon has held on. See, the sutures are seen. So it should be marked as A, B, C, D and gone proximally. So that's from me. Thank you very much. Thank you, Dr. Kim, and thank you for all the people for the patient hearing. If there's anything more that you want me to, you let me know, please.
Okay. Thank you, Dr. Usha. It was really very, very, I think, comprehensive and very illustrative talk. So I think I'm sure that many of us must have learned so much from the type of the surgical specimens and also how to handle and go about. I think there are 1 or 2 comments. I think there are 2 comments. I think in the chat box. Can you see the chat box?
Yeah. I'm just figuring it out. Just a minute. I'm coming to that.
Queries are there. I think you possibly have to attend to that.
Yeah.
The first one is what is the importance of hypertrophic nerve, possibly, I think.
Yeah, I have not concentrated on the microscopy because this is a pure grossing session. And, I think microscopy is another chapter and a day required to go about it. Hypertrophy they're all the parasympathetic nerve fibers which have come along from the sacral nuclei. So they are rich in acetylcholine, cholinesterase, and that happens only when they do not have ganglion cells. So That's the role of the hypertrophy, and people have tried to look and say the measurement makes a lot of difference. They should measure 40 microns, but it is truly impractical in day-to-day to sit and measure every nerve whether it measures 40, but it is not. The size does not matter. It's the number and how many of these is the, and the structure of it. Are they ropey? The way they look at whether they have a thick perineurium and how are they placed? Are they horizontal or haphazard? And always, these nerve bundles also have some amount of hypoplasia. We always, as students, we have been taught nerves, they don't undergo hypoplasia. But here, there's a very good example in Hirschsprung that nerves multiply. They do proliferate. They do undergo hypoplasia and hypertrophy. So this unique disease has a lot of things to get into our mind, that pathology is not as simple, but it's very, very interesting, because what you do for this child, you're going to save a child from making a wrong diagnosis. So you could save the colon, or you could rightly guide the surgeon how best to use his knife and how much to resect and not to resect more.
I think there are a few more.
Yeah, sure. You let me know. I will. I know I'm not able to see the chat box here. I think I have
Okay,
to.
the next one is, can you tell again about how to sample colostomy closure specimens?
Colostomy closure.
Specimen.
Closure, can that be defined clearly? I'm not able to understand what do they mean by closure.
Yeah, I think Nishta, I think you have to redefine again, write it down again down. I think the next one is, while sending donut margins, do the surgeons need to ink before sending, or
No,
we
no.
can embed either ways?
Yeah, donuts need not be inked. We know that it is the most distal portion of the anastomotic site that they want to know how well it is innervated. So we need to sample the entire circumference, and we'll study the whole thickness, preferably the mytric plexus, because what is seen in the mytric reflex is reflected in the submucosal. So if the mytric plexus, we expect them to show ganglion cells and no hypertrophic nerve bundles. And the ganglion cells should also be well spaced out, and they should be of an adequate number. And hypertrophy also, it depends in how many quadrants are they seen. So in other words, trying to say, yes, is this donut normoganglionic in all 4 quarters, or it is hypoganglionic, or that means not many ganglion cells, but has hypertrophic, then it falls into transition zone. So we need to say whether the donut is in transition zone. If so, how many quarters are in transition zone? See, 1/8 or even 1/4 we permit, and they say that child will overgrow, as the child develops, the ganglion cells might migrate, could, migrate down. But if it is more than quarter, I'm afraid, and we have done our studies and proved that they do not do so well. They need, sometimes that is why if the frozen is done and if we guide them, they will go 5 centimeters proximal to that, and that I'm sure would be well innervated. So instead of redoing the surgery after 3 days when the paraffin section comes, so they prefer that we do a frozen. But sometimes surgeons are overconfident. They send it in formalin and we tell them, I'm so sorry, your donut is in transition. Then they go back and redo surgery. So we should best avoid, redo surgeries on these children.
The next question partially is the same. Please explain the colostomy closure specimens again, ma'am. The same, I think, is asked by another person. Okay. So the next 2, 3 are, I think, appreciating your nice lectures. Okay. And saying that it's Usha ma'am is excellent as always, and thank you very much. I think after that is ACE enzyme study is still recommended or something?
Yes, we would, in our Indian scenario, it is very much recommended. It still holds the gold standard because the amount, see, many people try to say calretin is going to be the gold standard. But provided if you have, see, calretinine, by the time you report on it, it takes 3 days. Do you think a neonate of 1 year or say, sorry, 1 day or 4 days, 3 days, can you wait for 3 days? It may even take 4 days because you want it, well processed. Then IHC takes 1 whole day. Then you report. Certain things cannot be, we cannot hold on. So that way, acetylcholinesterase, you can report in 30 minutes. That's all it requires. Cut a frozen and report on the enzyme histochemistry, and be careful how you drain out the material, because acetylcholine is said to be carcinogenic. That's the only hassle. But if well washed out in your sink after you have stained, there's nothing wrong. The degree of specificity is so high. It is like almost like 99.99%. And sensitivity is almost like 90%. So it's as good as, so it's been considered as the gold standard. But the West do not follow ACHE because they do not have patients who will not come to them. They know that the patients will come back for their follow-up. But here we are afraid that if after the biopsy, we know that many patients don't come back. They prefer to do enema even, that goes on. So Indian scenario of health is very different from that of the West. So the West is not ready to take ACHE for the simple reason because they will go for lawsuits if they go make a mistake. Because ACHE, if you say positive, resection is done then and there. So, but here, if you're confident, we regularly use acetylcholinesterase, so I can swear by, that it is the best and very convenient. But if there is an issue of the least, say 1%, don't hold back from your report and say, yes, wait for the IHC to be done.
So Dr. Rupa actually, her question is utilization of calretinine in her Hirschsprung disease. Possibly, I think already partly answered, or you want to add something more?
Calretin, I think we should have a session for it itself. I thought this was grossing, so we are not talking about IHC. We're not talking. I just touched upon it because you have to handle the tissues for these. So I just thought. Okay.
Again,
So
I think,
Dr. Kim, I thought I'll welcome all of them to our annual hands-on workshop, which will be held for 2 days every year. But last year we didn't hold it because of the COVID. So we hope that we'll come out of the COVID and we could have this workshop again. So welcome to you all. And thank you, Dr. Kim.
I think there are more questions, but so you got the information, Nesta? You can attend a workshop?
Yes.
Yeah, clarify all your doubts about the grossing and all. Okay, I think, they were saying, sure, ma'am. So she'll attend. Okay, Nista is one of our DM students, actually. Okay, anyway, we have to thank you, Dr. Usha. It was really a fantastic talk. I think even I myself had learned so much, and similarly, others would have learned also. Thank you very much. So we go to the next talk now.
Yeah, thank you.
And thank you very much, Dr. Usha. Thank you. Okay. The next talk is on the EMR of the ASD specimens by Dr. Anuradha Sekaran. So she is from AIG Hyderabad. I think she is, the right person to talk on this. She would be one of the pathology who sees maximum number of this type of specimens. Yeah, Dr. Anuradha.
Good morning, ma'am.
Yeah, wo dikha dena.
Am I audible?
Yeah, yes, you are audible and we can see you also very well.
Yeah, thank you, ma'am. Thank you. At the outset, I would like to thank you for inviting me for this meeting, and I congratulate you on the success of yesterday's good scientific deliberations.
Thank you very much. Thank you very much. Yeah. Now the stage is all yours. Yeah.
Thank you.
So you
today,
have to share your presentation.
Yeah.
Okay.
Can you see my slides now, ma'am?
No, it's not. It takes some time. Just share it. It takes maybe.
Yeah.
इसमें नहीं आ रहे उधर आ गए yeah I see sharing it आ रहे yeah now we can see it.
Okay, give me a second, ma'am. Yeah, so today I'm going to talk on the endoscopic resections of the GI tract. I would show both the grossing and share few of our cases. So as you're all aware, now we are in a new era of inter and multidisciplinary relationships between pathologists and medical gastroenterologists. And the medical gastroenterologists have taken over the partial role of surgeons, so, and wherein they are giving us specimens. And this is where we pathologists play a very crucial role in trying to give our colleagues an answer whether they have completed the resections or is there any need to go for further therapeutic procedures. So basically these EMR, that is the endoscopic mucosal resection, and the endoscopic submucosal dissection are therapies which are targeted for patients with superficial neoplasias both in the upper and lower gastrointestinal tract. So they are a potential cure for early stage malignancies, and these procedures help in optimal staging. They help to maintain the organ preservation. They are minimal invasive procedures, so it avoids major surgery, very useful in patients with comorbid conditions, and it helps in better stratification and guidance if additional treatment is required. So there are three basic techniques: simple polypectomy, the EMR, and the EST. So what is the type of procedure which is used for what kind of lesion? So basically in these specimens, we get mucosa and the submucosa. So the maximum that we can stage in these tumors is up to the level of T2, and the endoscopists usually target lesions which have an early submucosal involvement. Now, when we try to report these specimens, we try to divide the mucosal infiltration into M1, M2, and M3, wherein we are trying to differentiate between intraepithelial dysplasia versus mucosal infiltration, that is into the lamina propria or into the muscularis mucosa, and then whether it is infiltrating into the submucosa. Are the slides available, madam? Hello?
Continue.
Yeah.
मेरे को on कर. We can hear you. Please continue.
Yeah. So now when is it that we have to go for endoscopic mucosal resection? When the tumor is limited up to the muscularis mucosa. And EST is employed for tumors which infiltrate into submucosa, which is further divided based on the level of infiltration into SM1, SM2, and SM3, which I will cover in subsequent slides. And anything beyond SM2 is an indication for definitive surgery. So this is the main area wherein the pathologists play an important role in identifying the level of invasion. So what is endoscopic mucosal resection? They are basically four patterns of by which the endoscopist will give a specimen. One is where they inject and lift the endoscopic tissue. And second one is where they go for a cap assisted EMR, wherein they suck the tissue into the endoscopic probe. Third is ligation assisted, and four is underwater endoscopic mucosal resection. So in endoscopic submucosal dissections, basically it's an en bloc removal of the superficial lesions, and this is regardless of the size. So this technique, they inject a fluid into the submucosa and form a circumferential mucosal lesion around the lesion, and they inject a solution which will provide a submucosal cushion which is long lasting till the procedure ends. They use specialized knives, and this procedure is basically used for lesions within the esophagus, stomach, and rectum. It is employed in the colon and duodenum, but it is a difficult procedure, and this is where the expertise of the endoscopist comes into play. Now, what are the differences between EMR and EST? Basically, EMR is a piecemeal resection. It is a simple procedure to perform, but it has a limited curative resection. Sometimes we might require additional procedures. You will not be able to mark the oral and anal end. Comment on lateral margins is sometimes difficult. The assessment of pathological risk factors are limited to a certain extent, but the procedure-related complications are minimal. Whereas the EST, you get an en bloc specimen. Technically, it is more challenging, so you need a very expert endoscopist to handle this procedure. It has a very accurate curative resection with a low recurrence rate, enables accurate histological assessment and staging, as well as assessment of your pathological risk factors. And as I said, the procedure-related complications are there, but minimal in the hands of a specialist. So this is a piecemeal polypectomy, which you will get through your EMR specimens. And on your right is your ESD specimen, which is well clearly demarcated and marked. So what is the role of a pathologist in these specimens? One, we confirm a pre-procedure diagnosis, which is either made on the pinch biopsy or based on the endoscopic impression alone. We tend to prognosticate and stage the lesion, in particular for the invasive lesions. And for non-invasive lesions, we confirm whether the lesion is curative, whether the lesion was excised in total. We confirm the subtype of the lesion and evaluate the margins as well as the base. And in invasive lesions, we assess the histological risk factors, which play a very important role in analyzing the lymph nodal metastasis. And what are these which give an idea on the probable lymph nodal metastasis? One, a comment on the differentiation of the tumor, whether it is poorly differentiated or well differentiated. Evaluate the lymphovascular invasion, the depth of infiltration, and evaluate the high tumor burden in case of your colonic polyps. And look for the risk of margin involvement, because if there is any tumor left, it means there is going to be possibility of recurrence. So the most important step starts with the handling and grossing of these specimens, which need a systematic approach. Now, from the endoscopic suite, we usually receive containers like this, wherein the specimen is pinned to a corkboard and it comes on the reverse floating into the sample of formalin. So the first and the foremost step which the endoscopist plays in addition to retrieving the sample intact from the body is to place the freshly received specimen onto a hard surface, which can be a corkboard, styrofoam, or a wax block immediately with the mucosal side up, so as to prevent curling and shrinkage at the endoscopic site. There should be minimal stretching and pinning of the margins, and then fix it immediately, at least for 12 to 24 hours. Optimal is 12 to 72 hours based on the size of your specimen. As well as the most important step is to measure the size of the lesion at the level of the endoscopic room and take photography so that you can compare if you have any doubt on your histological analysis. This is particularly important for the endoscopist because sometimes the lateral margins can be very, very close to the lesion, and particularly in duodenal lesions, when the lesion is almost reaching the SM3 and the surgeon cannot go beyond that because there is high risk of muscular perforation. So it is very important that they photograph and map the lesion. Now, the advantages of proper pinning, as we have already said, it helps in the optimal evaluation of margins and proper orientation. The pitfalls are if the margins are rolled, you cannot assess the margins, particularly when you have an invasive carcinoma close to the peripheral resection. So we may not be able to conclude whether the resection was curative or not, and be careful to prevent overstretching. Now, once you receive the sample in your lab, the most important step to do before you go ahead is a macroscopic examination after optimal fixation. And what is that which you will record in your report? One, see what is the size and the number of tissue fragments received. Sometimes we can receive both a piecemeal polypectomy as well as an en bloc polypectomy. Note which is the oral end and the aboral end marked by the endoscopist and strictly follow the markings. Measure the entire dimension of the specimen and take 2 dimensions of the lesion. See what is the macroscopic type. Is it polypoidal? Is it elevated? Is it depressed? Is it flat? And measure the distance of the lesion from the nearest margin. And then ink the margins, both the base with a color and the lateral margin with another color. Note that the lateral margin or circumferential margin or radial margin in a EMR ESD specimen mean one and the same. And have a diagrammatic representation of the specimen or the lesion on your gross form, and take photographs of the specimen after you remove the pins. So this is a technically optimal specimen which you have got after optimal pinning optimal fixation, and after removal of the pins. If you notice, the margins are very smooth and they are not curled, so it's very easy to identify or ink your margins. Now, the next most important step is how do you gross your specimen? Take a tangent that touches the focus closest to the horizontal tumor margin. And always, the first shallow cut is carried out in the direction perpendicular to the tangent. And if there's any visible lesion, ensure that you include the visible lesion into your first section. And after that, the next section should be made parallel to the first at intervals of 2 to 3 mm. And the first section and the last slice should always be embedded on margin edge. And before you separate the specimens, ensure you just make shallow cuts, take photography so that you can coordinate with your microscopic pictures later, then make deep cuts and separate all the slides. So I would just show a video about the grossing here.
So we have the specimen of ESD, which is pinned to cardboard, and the oral and aboral end is marked. So firstly, we have to orient the specimen and take a picture before removing the pins. So without disturbing the orientation, we have to first ink the base of the specimen. Ink the lateral margin with blue ink, and we have inked the base with black ink for different margins. We have to measure the specimen. Now we measure as you can see, there is a nodular raised area in the specimen. So now we are measuring the size of the nodule. That is 1.7 by 1.8 by 1 centimeter. So the first margin is to be taken tangentially, which is the closest lateral margin. So according to grossly, this margin appears to be the closest. Okay. You have to take serial sections from oral to aboral. So as you can see, I have serially cut from oral to aboral end in 2 to 3 millimeter distance, and I have flipped an aboral section. Now I will be, after placing the first lateral section, I will be serially placing them in the cassettes. So as you can see, we have serially embedded all the sections.
So once we have taken this, the next most important and critical step in getting a very high quality diagnostically accurate report would be ensuring that you embed on edge your first and last specimens so that you assess the margins first, and ensure you don't put more than 3 to 4 slices in one block. I usually go for a single slice per cassette. And the problem which we face with poor orientation is there can be loss of your small or superficial tumor through trimming, and there can be loss of your deep submucosal tissue and your deeper margins. So if you can see on the right side, these are unsatisfactory sections which are produced with excessive heat at procedure. And when you're taking your H&E stain levels, take 2 or 3 levels initially, and later you may go for deeper levels when you want to assess the deeper margins or if you have got incomplete sections. And sometimes some lesions are missed or hidden, or the ink is not visible, or you have a very small amount of submucosa. Now, this is again where I would like to stress that the expertise of an endoscopist is very, very important, who can give us an adequate amount of submucosal tissue. So what are the artifacts of EMR and which make the diagnostic interpretation difficult for the pathologist? You see the first picture, it's a good pinned specimen where you are able to clearly assess all the layers and you have a very good inked margin. So it makes it very easy for you to assess your deeper and your lateral margins. And check the below one where there, because of curling, it is very difficult to find where is your inked margin because of the ink going up. In addition, we can have hemorrhage, we can have cautery effects, making difficult of the submucosal level of invasion, and there is loss of surface epithelium, or because of the suction, sometimes in cap-assisted EMR and ESDs, you can have fibrin deposition, and the tissue can contract because of the fixation in formaldehyde. So what all should be there in your pathology report? What is your ideal pathology report of an EMR ESD specimen? Mention the tumor site, mention the macroscopic type of the tumor, whether it was polypoidal, whether it is flat polypoidal, sessile, depressed, what is the size of the lesion, and then on microscopy, what are all the layers included in your specimen? You have mucosa, muscularis mucosa, submucosa. Sometimes you even have the difficulties of your duplication of muscularis mucosa and Barrett's, which I will show in the subsequent slides. Make a note of the type of the lesion, and what is that is whether it's polypoidal and all, and the histological subtype, whether it's a well differentiated, moderately differentiated, or a poorly differentiated tumor, whether it's a tubular type of carcinoma or a papillary type of carcinoma. And what is the size of your lesion? Particularly when you have multiple foci of tumor in your report, you have to mention the number of the multiple foci, what is the size range of these multiple foci, and sequentially measure all these lesions in millimeters and report them separately in your report. And for invasive lesions, the depth of invasion should be documented, which I will show you in the subsequent slides. A note on presence or absence of ulceration within your lesion, the margin status, both on the lateral margin and the horizontal margin, the presence of lymphovascular invasion, both your venous and your lymphatic involvement, any perineural invasion, what is the tumor budding, particularly in your colonic polyps, and a note on the additional findings of H. pylori, Barrett's metaplasia, chronic gastritis, colitis, etc. So the most important role, how a pathology report can affect a therapeutic management in Barrett's, I would just like to show in this slide that the endoscopist would plan for an endoscopic ablative therapy if it is showing a low-grade dysplasia or a high-grade dysplasia. But once the pathologist says in the preoperative or in the pre-endoscopic report that there is a focus of invasion into the muscle and whether it is showing a favorable histology, then he might only go for endoscopic ablative therapy. But if we are saying that there is invasion beyond, or if it is showing an unfavorable histology, obviously it needs further therapeutic and a different line of management. And in Barrett's, what are the important points to think? So there is duplication of the muscularis mucosa and there is distortion of muscularis mucosa. These muscles will prolapse into the superficial lamina propria. The muscularis mucosa gets thickened and duplicated. And in fact, the outer layer, which is more thicker and organized, is your actual muscularis mucosa. And the inner muscularis mucosa, which is the duplicated one, is disorganized. And this is the one which blends into your lamina propria. And then you have a space in between these two split muscle fibers. So it resembles submucosa, which causes diagnostic dilemmas that whether the tumor is infiltrated into submucosa, and the actual submucosa and the outer muscularis mucosa may be mistaken for muscularis propria, and you may end up in higher staging the tumor. So how do you identify the submucosa? It is by the presence of vessels of large caliber and fat, and sometimes if you have submucosal glands are included, it makes the job easy. So just when we go through these pictures, see the first figure where you have the superficial, the inner muscularis mucosa, which is very disorganized and it is merging into your lamina propria. Then you have a space between the muscularis mucosa, which mimics your submucosa because of the loose edematous connective tissue. Then you have the actual organ outer muscularis mucosa, which is your actual muscularis mucosa. And then below is your submucosa, where you have your thicker vessels. So this is very important because the complete staging of the tumor depends on what level you are going to mention in your report. And if you're not aware of this point of duplication of muscularis mucosa, you may end up in overdiagnosing the level of invasion. So then again, after this, you have two classifications based on which you can report. One is the AJCC 8th edition and the Stoll method. Now in AJCC 8th edition, intraepithelial dysplasia only is M1. It is subdivided into M1. Lamina propria is T1A and it is M2. And infiltration into muscularis mucosa is T1A but M3, and this is irrespective of level of invasion within your duplicated muscularis mucosa. And submucosal involvement is divided into SM1, wherein the infiltration is limited to your superficial Hello?
Yeah. Yes.
Yes.
Continue.
Yeah. So, and in the Stolt method, if you notice, there is subcategorization into M1 to M4, wherein M1 is your infiltration to lamina propria, M2 is into the superficial muscularis mucosa, M3 is into the duplicated space, and M4 is into your outer space. So it's very important that you write in your report which method of staging that you are following for the level of invasion. So I just want to show here, on the right is the AJCC, where M1 is intraepithelial, M2 is into lamina propria, and M3 is any layer of your muscularis mucosa. And see on the Stolt method, where M2 is your inner, M3 is your space, and M4 is your outer muscularis mucosa. So the thickened muscularis mucosa may be interpreted as muscularis propria. So these are the pitfalls we should be aware of, because we might overdiagnose it as PT2. And the space between the duplicated muscularis mucosa is interpreted as submucosa. So a T1A adenocarcinoma can again be overstaged as T1B. And a duplicated muscle strips seen among the non-invasive neoplastic glands raise a suspicion of invasive neoplasm. So you might overdiagnose an in situ or a high-grade dysplasia as an infiltrative malignancy. Now, this is a very crucial role which a pathologist plays, and it's only by experience and knowledge about the layers which can help you to give a correct report. So just to show that, on the right you have a normal mucosa, a well-defined muscularis mucosa and a submucosa, and see in the figure B, wherein you have these duplicated muscles. Of course, it's very easy if you have your submucosal glands, but sometimes it's not included. And then I've already told that it is submucosal invasion is divided into superficial, mid, and lower 1/3. But what is the significance of this, and what is that you're supposed to report in your final report? So you have to measure the depth of the submucosal invasion, and if the depth is up to less than 500 microns, it means it is only SM1. More than 500 microns is SM2. And beyond that is SM3, and this indicates a high risk for nodal metastasis, and this patient needs a very close endoscopic follow-up. So and again, the level of the submucosal invasion varies according to the organs, varies according to the type of carcinoma. Now in squamous cell carcinoma, SM1, that is infiltration into the superficial submucosa, is defined when there is infiltration only to a depth of 200 micron meters. Whereas in the esophageal adenocarcinomas and gastric adenocarcinomas, SM1 is up to 500 micron meters. And if you go to your rectum and colonic polyps, SM1 is up to 1000 micrometers. So you have to know where you are reporting, which site you are reporting, and these points are very, very important in your report. And how do you measure the depth? So depth of invasion is measured from the outermost extent of the outermost muscularis mucosa. And you can take help of special strains like a trichrome stain, or even employ IHC like Desmin to determine this when in doubt. And in cases where the muscularis mucosa is depleted and neoplastic glands do not extend beyond the bottom aspect of your imaginary muscularis mucosa, then better you classify them as intramucosal carcinoma. And if you note that your neoplastic glands are in the vicinity of a submucosal, large caliber vessels, then immediately upgrade it to a submucosal invasive carcinoma, even if you are not able to define the lesion with respect to your muscularis mucosa. So I would just like to show here that here the measurement of the depth should be from the outermost layer of the muscularis mucosa, and the neoplastic glands here are closer. This is your muscularis mucosa, this is your submucosa, and they're very closer, but still they are separated by a rim of depleted outer muscularis mucosa. So I will show it in one of our cases. This was a 67-year-old male who underwent an EST with a clinical suspicion of a nodular Barrett's esophagitis. We received a sample of 6.4 into 3.22 centimeters, properly pinned to the cockport with oral and aboral ends marked, and gross evaluation revealed a nodular lesion of 2 into 2 into 2 centimeters, which is at a distance of 1.6 centimeters from the oral end and 2.5 centimeters from the aboral end, and the distance from the nearest circumferential or radial or lateral margin is 0.1 centimeter. And then if you see the microscopic pictures, there were areas of columnar lined glands, and there were loss of the normal polarity. There was dysplastic glands, angular glands, and there were areas where it was showing infiltration into your muscularis mucosa. Now this is your deeper inked margin. This is your submucosa. So if you see, the glands have infiltrated into the muscle, and there is some amount of duplication of the muscle fibers here. You can still see some splayed smooth muscle fibers. So if you take the AJCC, irrespective of the type of muscle, that is whether it is duplicated or what, it is classified as M3. So submucosa is free here, the inked margin was free here. But if you go to, this is the still high power views where you can see the neoplastic glands within the stroma, and there were areas of goblet cell metaplasia, and there are still some areas wherein the glands were more high grade and they were fused, there were cribriforming areas, and still another area which showed a poorly differentiated component of signet ring cells, and these are localized within your lamina propria. So finally, it was an adenocarcinoma in a background of Barrett's mucosa with areas of low grade to high grade dysplasia and areas of poorly differentiated carcinoma with signet ring cells limited to lamina propria. The maximum depth of invasion was T1A, that is into muscularis mucosa, into the M3, that is the muscularis mucosa outermost layer. The base was free, lateral margins were free. There were no lymphovascular invasion or perineural invasion. And the depth of tumor invasion is linked to the risk of lymph nodal metastasis. And if you see the studies, they have shown that in adenocarcinoma and squamous, as the depth of invasion increases from SM1 to SM3, the possibility of lymph nodal metastasis increases as much as 55%, and so also in the other organs. So now we'll go to the gastric lesions. So in gastric lesions, it follows the same pattern, except that you have to make a keen note on the distribution of your undifferentiated type of carcinoma, and you have to look for presence or absence of ulceration within the lesion, in addition to all the factors which we have described in the previous EST specimen of the esophagus. So in stomach, when you have multiple histopathological types, then you should record each one in a descending order, that is tubular pattern more than papillary or more than polypoidal pattern. Then if you have differentiated, you have to make a note whether it's a well or a moderately differentiated, tubular or a papillary type of adenocarcinomas. And then if it's a poorly differentiated adenocarcinomas, or if it's an undifferentiated type of gastric carcinomas, these have to be documented separately. And as you're aware, anything which shows less than 50% of gland pattern falls under category of poorly differentiated, and the signet ring cells and mucinous adenocarcinomas fall into your undifferentiated type of gastric cancers. So when you have a differentiated type of carcinoma coexisting with an undifferentiated type, now it's always better that if you have several areas, like if you see the yellow areas are your lesions, and you are seeing that you have 3 different areas of lesions. So you have to measure the longitudinal diameter of each area and write them up separately, and then give the actual sum of the values, which indicates the actual extent of the lesion within your specimen. If your undifferentiated area is very small that you cannot measure it, mention it separately in your report. And if you have differentiated and undifferentiated mixed, then the differentiated carcinoma may be predominantly in your surface layer, and the deeper portion may show your undifferentiated carcinoma. Then you must take the entire thing as an undifferentiated type of carcinoma. So the assessment of the depth of invasion is as the deepest layer which is infiltrated and recorded by the T classification. And supposing you find vascular infiltration in areas deeper than the deepest layer of your tumor infiltration, go by the area where you have the vascular infiltration and record that as your depth of invasion. So for example, if you have your tumor infiltrating into muscularis mucosa, so normally you would have recorded it as T1A, but you have a focus of infiltration into your vessels in your submucosa. You have to upgrade the stage into T1B. And for cancers invading the submucosa, you have to measure the depth. And as I said, less than 500 microns is T1B, and you will measure from the lower margin of muscularis mucosa. And this measurement is done using the eyepiece micrometer, and of late we have all advanced microscopes which have an inbuilt scale. Supposing the muscularis mucosa is torn or it is eliminated, that you're not able to find the muscularis mucosa for you to evaluate, then you must measure from the most superficial part of the tumor to the deepest layer. Sometimes the muscularis mucosa cannot be identified because of an ulcer or scar within the lesion. Then you classify that lesion as a T1A, provided the lesion is localized only within the regenerative mucosa covering the ulcer scar, and you have no obvious infiltration into the submucosal tissue. And if it goes into the submucosal tissue, then you draw an imaginary line with intact muscularis mucosa. And you can use Desmond to help in identifying the muscularis mucosa. And if ulceration or scar is found within the lesion, this lesion is best classified as, this is according to the Japanese criteria, and as all of you are aware, the Japanese were the ones who are pioneers in EMR ESD, and they have started this procedure almost 20 years back. So most of the literature which we learn is all from the Japanese classifications. So if an ulceration or ulcer scar is found within the lesion, classify it as PUL1 and PUL0 if there is no ulceration. And biopsy-derived scars can be identified as a fibrotic focus localized within a small area. Then how do you assess the vascular infiltration? The presence or absence of vascular infiltration can be measured by the D240 to identify the lymphatic vessels. You can use an elastic Van Giesen or Victoria Blue to identify the elastic fiber stains. And what is recommended? Supposing you have intramucosal carcinoma, even then, if you have an area of an undifferentiated type of carcinoma, it's always recommended that you employ IHC to look for any vascular infiltration and express it as LY1 if it is positive and LY0 if it is negative. And if venous infiltration is present, express it as V1 and V0 when negative. And how do you evaluate the margins? Horizontal margin and vertical margins, and accordingly as positive is 1 and negative is 0. So I'll show this in the form of a case. This is an 67-year-old male who had an EST of a gastric lesion. We received en bloc specimen, and it was 3 into 3.6 into 0.3, which had an ulcerated area of 1 centimeter, and the margins were inked accordingly. And if you see, this was the specimen. We have taken multiple bits, and these are the microscopic pictures. You can see that it was a well oriented specimen. You can see the clear ink below of your margins. All the layers are very clear, your mucosa, muscularis mucosa, submucosa, and your inked margin. And you see that there's a transition from normal mucosa to these dysplastic glands. This is yet another view where you can see the dysplastic glands, and the lesion is confined or infiltrating to the lamina propria, and there is no invasion into muscularis mucosa. So in gastric carcinoma, invasion to lamina propria is T1A, and your base and lateral margins were free. So next is the duodenal lesions. This is a very, very critical area where only an expert can handle, because in duodenal lesions, mostly they are being done for duodenal neuroendocrine tumors. And as you're aware, most of the neuroendocrine tumors are submucosal. So to get a very clear margin is the crux for the endoscopist. So we received a ESD specimen with a specimen of 1.1 centimeter, and there was a raised nodule of 0.7 centimeter. It was less than 0.1 centimeter from oral end, and 0.2 centimeter from the aboral end, and around 0.1 centimeter from the circumferential margin. So this is a specimen. You could see that we have inked it and we have submitted in entirety. And this was the sections, and if you can see a beautiful lesion arising in your submucosa, you can see that your mucosa, musculus mucosa, are all free, and your inked margin is free. And this is the next part of the hyper view showing the tumor, which has morphology of a neuroendocrine tumor, still hyper view to show the neuroendocrine cells. And if you see carefully, and what is more important is this inked base is free. That means the endoscopist could completely shave the lesion away, and he has got an excellent free base. So this is the synaptophysin highlighting the tumor cells, chromogranin positive, and Ki67 was low. So it was a well-differentiated neuroendocrine tumor grade 1. Now, EMR ESD of the ampulla of Vater. So in these specimens, identification of ampulla is very, very useful to help visualizing and sectioning through the ampullary duct. And why is it so? Because assessment of the CBD, pancreatic duct, and ampullary duct resection margin is very important to assess adequacy of excision. Now, as you see in this picture, you can pass a probe through the ducts, but you should be very careful that if you use all your force, you might push the lesion more into the deeper part of the specimen, which can cause problems during reporting. And when you're taking sectioning, you should take sections through the ampullary duct, because you have to allow the evaluation of the ampullary duct margin and the resection base separately. Cautery artifacts sometimes make this a bit of difficult. Next, going on to the colorectal specimens. Now, we have an endoscopic surface pattern classification. This is basically to predict the histological class. That is, whether it's an adenoma versus serrated class, as well as also to determine the presence of features which are associated with a deep submucosal invasion. Now, with the upgrade of the endoscopy by using narrow band imaging, they are able to finally define the lesions, even make a provisional diagnosis about whether it's a hyperplastic or adenomatous polyp, and evaluate with accuracy the depth of submucosal involvement. So you have the NICE classification, which is the narrow band imaging type. And then you have the Japanese narrow band imaging, which slightly differs from the NICE. And you have the Kudo pit pattern. Now, why is it that we should know about this? Because when we get a colorectal specimen, we get it labeled as a type 1 NICE classification. So we should be aware of what the clinician is trying to tell us. So basically, this NICE classification divides into type 1, type 2, and type 3, where type 1 is a hyperplastic, type 2 is adenoma, and type 3 is where there is an invasive carcinoma. So they assess this based on the color of the polyp in comparison with the background. They evaluate the vessels, whether they are present or whether they are brown vessels or whether they are disrupted vessels. And based on the surface pit pattern, whether it is spotted or tubular, as you can see in the below pictures, based on which they are able to tell. And the Japanese modified further the type 2 into 2A and 2B, wherein they are able to say that the probable histology is a low-grade intramucosal neoplasia or a high-grade intramucosal neoplasia with the possibility of shallow submucosal invasive carcinoma, and a type 3 is a definitive deep submucosal invasive cancer. So based on this, they're able to analyze whether he's a candidate for ESD or not. And then, as we know, the lesions in the colon can be a non-pedunculated or a pedunculated polyp, and based on the size of the polyp, whether they are diminutive or around 10 mm or more than 20 mm, they can go for either polypectomy with either a cold snare polypectomy or a hot snare polypectomy, or go for an EMR, and if they are suspecting submucosal invasion, they can go for ESD. And if there is any deep submucosal invasion in your ESD, obviously it has to go for a surgical resection. And then endoscopic morphological classifications are of two types. This is again important because we get on the form that it is Paris classification so-and-so, laterally spreading tumor so-and-so. So what is this? A Paris classification is used to identify a superficial colorectal lesion based on the morphology when the depth of infiltration is not more than the submucosa. And this is subdivided into protruded, flat elevated, or flat lesions, and again subdivided into pedunculated, subpedunculated, sessile, or flat with excavated lesions. And the laterally spreading tumors, again of two types. Based on the granularity, they can either be non-granular or they can be granular. And why is it that it is important? Because these lesions have multifocal point of invasion. So it's very difficult for the clinician also to predict which is the foci where there could be infiltration. So there's very, very high chance of submucosal involvement. So a knowledge about this is very crucial for us also to understand what the clinician is expecting from us. So then you have the Japanese classification of the colorectal cancer and the Western classification. So if you see, the Japanese have subdivided infiltration into the submucosa as T1A if it is less than 1000 microns and T1B if it is over 1000 microns, whereas the TNM only gives it as T1. And then we have our histological classification, the Kikuchis and the Haggards. So particularly the Kikuchis is used for evaluating the submucosal invasion, whether it is SM1, SM2, and SM3, which we have already discussed. And then we have the difficulties in this. So what is the difficulty is if you have not got an entire submucosa, then it's difficult to divide into this arbitrary SM1, SM2, and SM3. And then you have to subdivide it into superficial submucosal invasion and a deep submucosal invasion. So if it is less than 1 mm, it's called superficial submucosal invasion, and this is very low lymph nodal mets. More than 1 mm, will have a high chance of nodal metastasis. And the Haggards classification is based on level 0 to level 4, where level 0 is intramucosal, level 1 infiltrates into the submucosa but limited to the head, 2, it infiltrates into the neck of the polyp, 3, it infiltrates any part of the stalk, and 4, it infiltrates into the submucosa below the stalk. So level 3 and 4 of Haggards are considered higher grade. So what are the qualitative factors we need to assess in a colonic EMR ESD? One is on the tumor differentiation. Second is look for the tumor budding. Evaluate and record whether it is high tumor budding or intermediate tumor budding. Evaluate lymphatic and venous vascular invasion, positive margin status, and go for MSI status based on your IHC. And the rest of the risk factors is similar to the rest of the GI tract. Now, what is tumor budding? It is defined as a single tumor cell or a cell cluster containing 4 or fewer tumor cells. And why is it important that we have to record this? Because it's an independent predictor of lymph nodal metastasis. And AJCC in updated 2018 protocol recommends that you make a note of this, and you can subclassify into grade 1 budding if it is 0 to 4 buds, which indicates low budding, 5 to 9 buds is intermediate, and more than 10 buds is a high grade budding. And what is the quantitative factor is measurement of the depth of invasion, and this is the most important step. So as I said, the muscularis mucosa is obscured or destroyed by the tumor, you have to measure the depth of invasion from the surface. And for your polyps and non-pedunculated polyp, the depth of invasion of 1 mm is considered as a cutoff for deep submucosal invasion and increased risk of nodal metastasis. So just if you see here, an arbitrary line which shows the muscularis mucosa, and if you can identify this arbitrary line, measure from this line to the depth of invasion as your SM1. But if your muscularis mucosa is obscured because of tumor, because of scar, because it is broken, then you have to measure the depth of invasion right from the surface down and record it. So for example, if you see this lesion, this is where you are able to define the muscularis mucosa. So you measure the depth from muscularis below, and this is a beautiful decimal which is clearly defining your muscularis mucosa and makes your job easy. So this is 800 microns. So according to Japanese criteria, it comes under SM1. and it still has a low risk of nodal metastasis. SM2 and SM3 is SM2 is more than 1000 and SM3 is more than 2000 microns. So this is one more area where the submucosa where the presence of venous lymphatic invasion cannot be documented because there is a shallow dissection of your submucosa. Whereas if you go to the second picture, you have an adequate submucosal dissection. So this helps you to evaluate venous lymphatic invasion. So document in your report whether you have got adequate submucosal tissue or not. And margin involvement is very important because it doesn't predict lymph node metastasis, but what is an adequate clearance? More than 1 mm or some recommend 2 mm. And if it is more than 2 mm, it's definitely not associated with recurrence. So in pathology reporting format, it is almost similar to your previous thing, but you have to make a specific note on the type of polyp morphology and size, and whether it was pedunculated or sessile, and whether it was piecemeal or en bloc. And if you have got both, measure them separately, and definitely make a note on the tumor budding. And keep in mind, SM1 differs for colonic polyps. And a simple polypectomy, as we have already said, it is for polyps less than 10 mm. And how do you gross these polypectomy specimens? So again, these lesions should be bisected head to stalk, and the cautery burn on the stalk usually gives a good marker to orient your specimen. If the sections are cut without proper orientation, you will not be able to evaluate the margins. And once the lesion is sectioned in a plane perpendicular to the plane of resection, then the entire lesion should be resected at 2 mm intervals. This is just to show a polyp where you, which is having pedunculated. This is the base of the polyp. Ink it separately and then bisect it into half and then submit into parallel sections. So this is the microscopy of the same polyp where you can clearly see your inked base, and this was free and just a tubulovillous adenoma. So this is just one last case. So this is a 59-year-old male, a polypoidal lesion in the sigmoid colon. So JNET classification was type 2. Paris classification is IS. Grossly, we received an EMR pinned to the cockboard, measured, and but oral and anal end was not marked. A raised polyp was noted. It was around 1 to 1.1 centimeter, and it was 0.5 centimeters from the lateral margin. And if you can see the microscopy, there is transition from benign to dysplastic, and they are infused glands and cribriforming, and these are infiltrating the lamina propria into the muscularis mucosa and into your superficial submucosa, and the depth of invasion is less than 1000 microns, so it is T1A. This is where we have employed the Desmond stain, and you can clearly see it is nicely identifying your muscularis mucosa, which is disrupted in between. So this was a well-differentiated adenocarcinoma in a background of adenoma. And when we say it is less than 1000, it indicates that the endoscopist has done a very nice job of saving the patient from a surgery. And this is sometimes when we receive both a piecemeal as well as pinned specimens, you have to make a separate note of your fragmented as well as your pinned specimen. And these are the sections from the specimen, and it was a tubulovillous adenoma. The margins were free, focal areas were showing high-grade dysplasia, and submucosa was free. So to conclude, a standard comprehensive pathology report allows optimal staging, better stratification, and a guide for additional treatment. And remember that the depth of submucosal invasion varies from organ to organ and on the type of the carcinoma. Assess your lateral, deep margins, and vascular emboli. Thank you.
Thank you very much, Dr. Anuradha. It was very, very comprehensive and very detailed talk. And I think we have encroached into the next session for, I think, yeah. So I think we are not going to entertain any of the questions. There are a few questions in the chat box. Possibly they are not very important. Ek minute. They are not very important. I think they can do reading up also about the tumor buds and everything. All these would be possibly available in the textbook. So I think the queries can be handled by themselves. I think with this, I think I have to thank you very much, Dr. Anuradha. They were fantastic. Your photographs are really very good. I think it's your own collections. I really appreciate your contribution. Thank you very much.
Thank you, ma'am. Thank
So
you
I
so
think
much.
with this we go to the next session, and it is on APRs and other colectomy specimens, and this is none other than Dr. Rupa Paulos. Yesterday also she had given us a fantastic talk on GIST. Dr. Rupa, good afternoon. Sorry because it got delayed by 20 minutes. Yeah. Anyway, we'll give you more time. Yeah. Okay. Dr. Rupa ka wo dikha dena thora. Yesterday also we already have seen her biodata, but let's have a look into this again. Yeah. So she's a fantastic GI pathologist from Amrita, from Kochi, and a very good orator. And so I think with this introduction, Dr. Rupa, the stage is all yours. And you get 20 minutes more, huh? Don't worry. Okay. Take your own time. Thank you. Thank you very much.
Madam, can you hear me? Can you see me?
Are you?
Can you see my screen?
Yes, we can see you, but I think your screen is yet to come up.
One minute.
Okay. Screen has come. Yes, we saw yours.
Screen has
We
come?
can see. Yeah, it's come.
Okay.
Go ahead. Go ahead.
Screen has come, madam. Can you see my screen?
Actually, we are seeing it in the YouTube, but we are not seeing it in the thing.
Okay, 1 minute.
Just try sharing it again. Just,
yeah, 1 minute.
Just try sharing it again.
Ryan.
It takes time. Yeah, it will come on. It's okay.
Ryan.
It's not coming up. We have also your presentation, Dr. Rupa.
Sorry, sir, 1 minute.
We have your presentation.
So I have.
Was the presentation?
No, I have one.
You change something, make some changes. Other we'll try sharing it. We have your presentation with us also. अनुराधा तो हो गई ना अभी. Yeah, it's come. It is there, the screen, we can see. अनुराधा का हमारा ठीक है. Yeah, we can see it.
Okay,
yes.
Okay.
Go ahead. It's okay. Go ahead.
Yeah. Thank you, madam. Thank you. I wish to once again express my gratitude to Kim, madam, and the entire organizing team for having this wonderful conference. You know, as madam clearly said yesterday, about 30% of GI work of most labs and pathology departments is GI. So this is absolutely topical, and thank you so much, madam, especially in a time like Corona where we are really not seeing each other, but having something virtual as this is great. And thank you for having me part of it. And I'm only too happy to contribute to your program. So today, Madam asked me to speak on the challenges that one faces with colorectal resections. So I have actually incorporated both the gross and also a bit of the microscopy so that we understand the practical difficulties with the gross. So that's roughly how we will see this talk. So for all those who are here, I'm sure you have no doubt that we as pathologists and our pathological assessment plays an extremely crucial role in the post-surgical management of the patient and also for prognostication. I mean, if and when we are absolutely clear of this, then everything else that goes with our work, reflects that. Because when we are clear of what the implications of our work is, then our work just reflects what we do. And one of us, we are all following the TNM 8th edition. But however, I'm sure on an honest, if I were to ask you honestly, there are challenges and we do face them at a practical level. And sometimes it could be because of, the lack of clarity on the existing guidelines, or because there are some newer concepts that has come out. So in this talk, I'm actually trying to address, or I will aim to address some of these challenges that we face, both at a grossing level and also at a microscopic level. So this is roughly what the talk will be about. So at the outset, when somebody does get a resection, a colorectal resection, it's useful to know, or it's important to know, what is the specimen that you're handling. So many times I ask a resident, what specimen is this? Now it might seem like what is that question all about? But then, are you dealing with an AR, or is it an LAR, or is it an APR? Well, it's important to know that, because the way you would handle it and the assessments that one makes regarding these various specimens is also different and important. So important to know what is the sort of specimen. Also, in addition to the rectal specimens, one also gets the right hemis and the left hemis, and also a proctocolectomy. So important to identify what we are dealing with, because our approach will be tailored according to the specimen. The second thing to note is the site of tumor, or usually the clinicians let us know that this is a cecal tumor or a rectal tumor, which is useful to know, because sometimes there may not be any tumor at all, and yet they have said, or vice versa. Again, if in the context of familial cancers, it's quite useful to know, especially if you are seeing a lot of background polyps, or if you're seeing a lot of ulceration, whether there was a history of IBD, should either alert to you if that information is not communicated to us already. Preoperative therapy, again, an important or a useful piece of information that one would like to know. So ideally, these specimens, they come fresh and unopened, and before you handle, or just before you start grossing the specimen, after it's been fixed, please do have a really good look at the external exam, at the serosa, and do a thorough external examination, because there may be very small areas of pathology that one might miss, and especially if one did not recognize it at the gross, it would never get picked up on the microscopy, and clearly that would have implications on the patient management. So do have a really, really good look at the gross externally, and I will show you in a while why that is also important. So pay attention to that external aspect, look for any defects. Is there any perforation? Is there any serosal involvement? Photograph. As you can see, I know many of the photographs are our own specimens, because they are actually, they give us a permanent record of what we had seen, and it's also useful to show the clinician if there was a doubt in it. Anterior peritoneal reflection, this was already been discussed, but I will just allude to that in a minute. So what is this anterior peritoneal reflection? Pusha madam has clearly told us the importance of the anterior peritoneal reflection in Hirschsprung's disease, but it also has an important role in the context of CA rectum. Now, this anterior peritoneal reflection is this peritalized surface, which comes down to about 2/3, between the 1/3 and 2/3 of the rectum, and then reflects upwards onto the bladder. So why is this important? So which means that in a rectal specimen, we have one aspect, the anterior aspect of it, which is partially covered by the peritoneum, and it is at this point that it has got reflexed upwards or anteriorly onto the bladder. Now, just as this is the anterior, this is the posterior. So which means we have an area which is like a triangle, which does not have any peritonealized lining. All of this is extremely important in the context of rectal cancer. The reason being, if there is a tumor which is above the anterior peritoneal reflection, it clearly has a peritonealized covering over it. However, if there is a tumor below the anterior peritoneal reflection, it does not have the peritonealized covering, and therefore it is almost exposed to the pelvic region. So this in turn makes it important to assess that margin, which is the circumferential radial margin. So always, as I was mentioning to you, it is important to identify this anterior petrous reflection and also note where the location of the tumor is with respect to this anterior petrous reflection. Now, why is this important? In the past, it was thought that those tumors above the anterior petrous reflection did not require chemotherapy, or would not be amenable to neoadjuvant chemotherapy. But today we know that is not true. And we know that even those tumors, those rectal tumors which are above the anterior petrous reflection, the rectal carcinomas, do receive neoadjuvant. So there was an implication on that respect in the past. But today, this anterior petrous reflection is even more important because those tumors which is below the anterior petrous reflection clearly has a circumferential radial margin. So then we will come to the next important aspect, which is the total mesorectal excision. Now, this involves the removal of the perirectal tissues, that is both on the lateral aspect as well as around the circumferential aspect around the rectum, which actually entails removal of the entire mesorectal envelope. The surgeons clearly understand the utility of this total mesorectal excision. In fact, it reflects it reflects the quality of the surgery, and to the surgeon, he takes pride in this total mesorectal excision. And the reason for that is that a high quality TME surgery actually reduces the local recurrence from a fairly high 30% to even less than 8% or even less than 5%. And clearly that improves the 5-year survival significantly. So you can imagine the importance, the importance of this TME surgery. In addition, if this patient had neoadjuvant chemotherapy and together with a high quality TME, that considerably reduces the risk for local recurrence. So that is from the surgical perspective. What about us as pathologists? This is equally important for us because we, in some ways, are trying to give an audit or trying to tell the surgeon how good his surgery was. That's one of the indirect things that we do on assessing the mesorectal excision. But more importantly, it tells a good resection and a good excision is important for prognostication of the tumor. So how do we make this tumor mesorectal excision? We look at the bulk of the mesorectum. We look to see if there are any defects in that mesorectum. We look at the regularity of that CRM that I have mentioned, and then we will look for any distal coning. So all this is pertaining to the rectum because I think that is the more difficult areas of that. Those are the more difficult specimens as opposed to the right hemi, which I won't be really touching upon today. So just to look at this, this is an LAR, and we can clearly see an anterior petrous reflection here, and there is this area that is below the anterior petrous reflection, which I had told you was the circumferential resection margin. Now the tumor is here. So as you can imagine, the most important margin for this tumor, which is below the anterior petrous reflection, is this circumferential radial margin, which is there anteriorly as well as posteriorly. Had this tumor been here, then the most important margin, because this has an anterior petralized surface, the most important margin would be this posterior non-petralized radial margin. So all of this, I'm once again highlighting the importance of this non-petralized radial margin, which would be a posterior non-petralized radial margin if the tumor is above the anterior petrous reflection, but would be a circumferential radial margin if the tumor is below the anterior petrous reflection. It is for those reasons that one actually inks them. Now, if you don't have two colors, that's okay, but as long as you know that this is anterior and this is posterior. So that was a little bit about the, again, reiterating the importance of the circumferential resection margin. We will now look to see how are we going to make this assessment of the surgical excision. So if you were to look at this, this is a really good specimen. This is taken from the Royal College of Pathologists data set. And here the bulk of the mesorectum is good. The mesorectum is shiny, it is smooth, and there are no defects. So really, this is an extremely good resection that the surgeon would be proud about, and we would be happy to see, because this also ensures us that we are going to get a good nodal yield, which is important for the patient prognostication and staging. So this is a mesorectal excision. Now, if you were to look at this here, the bulk of the mesorectum is not great. It's moderate. But more importantly, there are defects. In fact, there is a defect that is more than 5 millimeters, but the muscularis propria is not exposed, fortunately, for this patient. And there is a little bit of distal coning. So in this context, the mesorectal excision isn't great, but it's moderate. So we would call this as an intramesorectal excision. But if we were to face something like this, whereby there is absolutely no mesorectum even around this in this specimen, and what we are actually seeing is muscularis propria being exposed. Now, this is a it's a pretty bad surgery, and there would be a risk for recurrence, a very high risk of recurrence, and also it would mean that the tumor would be quite close to that important CRM, making it a high chance of giving it a high positivity for a CRM, and also suggesting that there would be a very high risk for local recurrence. So something like this is not encouraged, and clearly should also be should be reported back to the surgeon. Now that was the AR and the LAR. We'll now look at APR specimens. So as we know, the APR specimen, it has the anal canal also included in the specimen, and these are really for low rectal tumors. So if you were to look at this specimen externally, what you see is again a very good mesorectal bulk. There is no distal coning. And also importantly, it shows these levators, which are also included within the specimen. In fact, the levators are attached to the mesorectum, suggesting that this plane of excision has been beyond the levators, and that is how the levators have been included in the specimen. So this is an extremely good resection, and we would call this as the extra levator plane of surgical excision. If you were to compare this picture with the previous, we can clearly see that the mesorectal bulk is not great. In fact, this is the levator, which is just sort of struggling to remain there, but clearly not quite attached to the mesorectum. This is the sphincter muscles, and the sphincter muscles are exposed. There are a few defects, and there is distal coning. So this is not a great resection, and this would be a sphincteric plane of excision. And then when we are faced with specimens like this, where it's disheartening that that the specimen has come out in this manner, probably maybe due to technical reasons, or maybe because of lack of expertise. But something like this is a really poor resection, in that it has exposed the muscularis propria. In fact, it has exposed the submucosa and resulted in tumor exposure also possibly, and the risk of recurrence is very high. In addition, you can imagine that the lymph node yield in the specimen would be very poor, suggesting that there could be nodes that's remaining in the patient, which may be positive, and again ensuring or suggesting a poor prognosis. So it is for these reasons that one assesses the surgical plane of excision for prognostication, and also to ensure the accurate and also as an audit to reflect the surgical quality to the surgeon. So moving from the plane of excision, we will now look at once again the importance of the CRM. So as we said, if we had tumor that was, if the plane of surgical excision is poor, then the risk for the tumor to be at that circumferential radial margin would be high, and that would mean that there is a high risk for local recurrence. Now, having seen what the tumor looks like grossly, we would slice into the tumor. And when we slice, we actually can see the depth of invasion. It is important to look how far beyond the muscle layer has this tumor extended. So we actually give a distance of this extramural spread beyond the muscularis propria in millimeters. We do it at the gross level. We also do it at the microscopy level. Then, having seen that the tumor, this is the advancing front of the tumor, and that is the CRM, we also give a measurement of the distance of the tumor from the CRM or the non-petalized resection margin, again in centimeters or millimeters as per the case may be. If this tumor has come all the way down here, then that is clearly a positive margin, or even if it is less than a millimeter, that's again considered as a positive margin. However, if you had a tumor that was that had a good clearance of at least, let's say, more than 2 millimeters from this CRM, but we had a node that was very close, less than a millimeter from the CRM, which may be positive, that again suggests that this is a positive radial margin. So therefore, at the gross level, when one slices through the tumor, you should look to see the extent of the tumor beyond the muscle layer, or what is the extent of tumor, and if it has crossed beyond the muscle layer, how far has it crossed beyond the muscularis propria. Additionally, we must pay attention to the deposits that may be there adjacent in the vicinity of the tumor. And when I say deposit, it could even be nodes. So always try and take a section to note the distance of that node to this radial margin. Because if this node is positive, and if it's less than a millimeter, then that would also mean that it is a positive radial margin. So a positive CRM implies tumor extending to that margin. It also implies that there could be LVI or PNI at that margin, or a positive node at that margin. So all of this, this sort of information can be given only with somebody who's got a very good eye at the grossing level. If you miss this at the gross, we have missed it at the microscopy level also. So I cannot reiterate anymore that a really good grossing is the start for a really good report. Now, again, I'm emphasizing the fact that there is that the CRM is important, because for the rectum, this clearance is actually, this clearly predicts local recurrence and also the survival and the outcome for the patient. Now, a local recurrence, if this is a positive lymph node, is about 12%, but if it is direct tumor extension, it's about 24%. So this has to be conveyed to the clearance or the state of this circumferential radial margin should clearly be mentioned in the report, and if it is very close to the CRM, that again should be conveyed at the multidisciplinary team discussion, because this would mean that the patient could benefit from adjuvant therapy, adjuvant RT, to prevent that local recurrence. So we will now come to the next important aspect of our assessment of colorectal specimens, and which is serosal invasion. Now, serosal invasion, they say, is about 60% in, when they did a study, but they have also found that it is very commonly underreported. Now, many times we pick up the serosal infiltration or the serosal involvement because of a meticulous grossing, and also because of adequate sampling. Now, if you were to see something like this, you may miss it, you may not miss it, but do pay attention to any sort of a retraction, puckering, granularity, or hemorrhagic areas, gray-white areas, exudates, all very, very important. Now, that is something that we can see, on the surface. But I also would like you to pay attention to what is there in the fat crevices. So this is what I meant. In the fat crevices, you could have tumor that is just puckering its way or finding its way onto the peritoneal surface, but it's tucked away because of the fat that is obscuring it. Now, if we miss this, then this will be understaged, and therefore the patient would not be benefited from the adjuvant therapy that this patient should be ideally getting. So I would like to emphasize the importance of looking into the fat crevices also at the vicinity of the tumor. Now, this was a specimen whereby the specimen came, it was just opened by the resident, but if you look carefully, we've just cut right through the tumor because there was an area of very, very likely or a very strong suspect for serosal perforation. So at times like this, where you have got a suspect for serosal perforation or serosal involvement, at least a minimum of 2 blocks from that area is important. Now also, I hope you have understood, do not, as soon as you get the specimen, do not ink it, because there is a lot of information that the specimen wants to tell you, and you might miss it because we've just seen it and inked it and then just crossed it. So, take a, pay attention. It's worth paying a lot of attention to that external aspect. And then we'll come to the next challenge. We've now sliced into the specimen, and we've seen the tumor looks something like this. We've got tumor that is this is the surface, this is the radial surface, and we've got tumor that is coming ever so close. Now, this is a PT4 or a T3. That would be the dilemma here. And these are, as our AJCC guidelines say, that a tumor that has invaded through the visceral peritoneum, which also includes gross perforation of the tumor, or if there's a continuous invasion of the tumor through areas of inflammation to the surface, then that makes it into a PT4. Now, that's all very easy. We know that's what the statement says, but there are challenges. Sometimes you may have a disrupted overlying mesothelial layer, and then you do not know whether that was disrupted. Was it because of the specimen handling, or was it a true serosal breach? Is it an artifact? Sometimes there may be a lot of fibrino-inflammatory exudate, which may be a reaction to the tumor. So does that mean it has perforated? Is that a serosal breach? So these are some of the challenges that one faces. And of course, if you have spotted that serosal perforation or that serosal puckering in the fat crevices, do not overlook into it, because that could also reflect a possible serosal involvement and a potential T4. So this is what I was trying to show when we had seen in that previous case, where we saw those, how the tumor had come ever so close to the surface. And here it is. We've got these glands coming just near the surface, maybe possibly perforating the surface also, the serosal surface. Or alternatively, it can look like this, whereby the glands haven't quite reached the visceral surface, but there is a little bit, it's less than a millimeter, and there is an inflammatory infiltrate that separates the tumor from the surface. Alternatively, you may or may not see something like this, but if you do suspect, if you do see areas whereby the tumor is coming close, or it has there is an inflammatory exudate, take a couple of deeper levels, and that can help to resolve the problem. As we had seen in this particular case, a couple of deeper levels help to show that this is the peritoneal lining, and there is a breach, suggesting that this is a T4 and not a T3. And the same here. So therefore, the answer when faced with challenges is multiple serial levels, and go back and it's worth a second look at the specimen to see, was there any other, especially when you've got a suspect between a T4 and T3, go take a couple of multiple deeper levels of the tumor sections that you've already got, and perhaps just go back and have another look at the specimen. There may be a worse area. So to just so that we have clarity, when the tumor is less than 1 millimeter, even if it is associated with inflammation and granulation tissue, it's better to upstage it to a T4, because the risk of peritoneal perforation would be much higher. In fact, studies have also shown the same, that a tumor that's less than a millimeter tends to behave like a T4, T4A. Now we'll come to the next important aspect, which is the extramural tumor deposits. Now, this is a specimen of ours. As you can clearly see here, that's mucosa, but do you see tumor? And the answer is no. Okay, so there was actually no tumor. This is the slice that was adjacent to the tumor. And what we see are multiple deposits. In fact, I think if you were to look close enough, you can identify that this is a vessel. And we've got tumor deposits here also. We've also got tumor deposits here, and perhaps here. So this is a section that is taken from where there was no tumor in the mucosa. So extramural tumor deposits are those which are clearly discontinuous and that's within the that's within this extramural area. So what do we understand about these extramural tumor deposits? Are they nodes which are completely replaced by tumor? Do they reflect LVI or PNI? Okay, all worth considering. Now, it is important to distinguish the extratumoral deposits from LVI and PNI. And the way we do it is by looking at multiple deeper levels. One can do elastin stains to identify between lymphovascular emboli and tumor deposits. And clearly, these tumor deposits imply poor prognosis. And nowadays, we are encouraged to say whether it's more than 5 or less than 5. Now, it is thought that these extramural tumor deposits probably has originated from a focus of extramural LVI. Now, extramural tumor deposits, we call them when we are very clear that it is not a PNI and it is not an LVI and it is not a node that's replaced by tumor. So if you've got a discontinuous, discontinuous extramural tumor which is very ragged on its or externally, sorry, when I mean which has very ragged edges and which is not a node, when you're sure it's not an LVI and when you're sure it's not a PNI, that's when we call it as an extramural tumor deposit. Now, why is it important? Sometimes you may be faced with a tumor which looks like a T3. There is no serosal perforation and nodes are all negative. But having an extramural tumor deposit puts it into a T1, into a PN1C category. And that would be an indication for adjuvant therapy. And similarly, you could find the same even in a T2 with an N1C would again put it in would require adjuvant chemotherapy. So then coming to venous invasion, because when we see those deposits in the mesorectum, the first thought is, are they extramural tumor deposits? The next dilemma is, are they venous invasions? So by convention, or this was the historical definition, that venous invasion is a tumor that's present within an endothelial lined space, either surrounded by a rim of muscle or containing blood cells. Now, venous invasion, now in our practice, we try and categorize them as being intramural or extramural. We try and give the depth of the venous invasion as saying whether we have got extramural LVI. And this has been shown to be an independent prognostic indicator. But the fact that whether lymphatic and the small vessel invasion also has now been shown to be an independent prognostic indicator, which was uncertain in the past, but now we are encouraged to report it. Now, if we need to report it, because many times the radiologist tells us that there is extramural LVI, and this sort of reflects what they find and what we find. But there are challenges in this also. There could be tumor retraction, or one may not be able to identify the vessel wall itself. So this is just to show that when you see nodules like this, you must take sections from them because this could just be a tumor deposit, a tumor nodule, which is right next to a thick-walled vessel. Now this is called as an often arteriolar sign, because on deeper sections this would show that this is actually a vessel. There is a vessel wall with tumor within it. Similarly, when you see protruding tongues of tumor like this, do consider the possibility of vascular invasion. So all of this again is back to our gross. So one needs to pay attention to what we are seeing in that subserosal fat also, which may be in the vicinity of the tumor but away from the tumor also. And this is just to show these nodules, which under the microscope would be seen something like this as tumor nodules. And if one were to apply the elastic stains, they are highlighting that they are actually vessels, and this reflects LVI. And actually identifying LVI also is an indirect reflection of the quality of our work, and also important for prognostication, because LVI reflects lymph node metastasis as well as distant metastasis. So that was to show, if in doubt, do not hesitate to use an elastic stain because that would help to resolve a challenge that you may be facing. So moving from LVI, we'll now look at the lymph node yield. Of course, we know that lymph node yield is highly predictive of the patient outcome. In fact, it's one of the major determinants for the postoperative chemotherapy, meaning a lymph node yield in chemotherapy specimens, we do not get much of a yield, but it is important that we try and identify as many nodes as possible within the specimen. Of course, a 12 node has been recommended as the standard, but anything, one need not limit ourselves to a 12 node. It could be anything more than that. Many times you can have very tiny small nodes which have been involved by metastasis, and therefore, it's worth going through a diligent search for these nodes. But there are many factors that affect lymph node yield. It could be the surgeon, it could be the type of specimen. If it's not a great resection, of course, and if there's not so much of a mesorectum, we are in some ways affected by the lymph node yield. It also depends on us as pathologists, the skill, the diligence, and the methods that we can use. It also affects, it's dependent on certain other factors like right-sided specimens, microsatellite instability, and they say women are associated with higher lymph node yield. Of course, if the patients are obese or if elderly and in post-neoadjuvant therapy, then the lymph node yield will be much less. We are also aware of visual enhancement techniques like fat-clearing solutions, xylene, acetone, or one can even use glacial acetic acid, ethanol, distilled water, and formaldehyde fixation for better lymph node yield. But in my opinion, a diligent search is all that is required. I do not really go into many of these fat clearing solutions because we have, a diligent search should suffice. And now the importance now, one would understand why we need to be diligent about our lymph node yield is because we do not want to understage this tumor. Now, a tumor that is a T3 and N0 because we've only got 5 nodes and it is an N0, that could be a mixed stage 3. So many a times, if we have not got an adequate node, I do let them know at the multidisciplinary team meeting that this is a T3 N0, but it's 0 out of 8 or 0 out of 10, whatever, so that they know that there was, we have not got that many nodes. And it has been clearly shown that the higher the lymph node yield, the better the survival, both in a stage 2 and in stage 3 cancers. And also, it also reflects a higher lymph node yield, also reflects the immune response of the patient to the tumor. So we know that in NACT specimens, the number of nodes would be much less, the lymph node yield is much less, but nevertheless, do be diligent about dissecting the nodes even in NACT specimens, because that also a low lymph node yield also has been shown to have a negative impact on survival in rectal cancer patients. So I just thought I would just put out this little challenge that one might face when reporting colorectal cancers, and that is that you have seen that there is acellular mucin in a lymph node. Now, this is not uncommon in a neoadjuvant setting, but what do you do if this is but if you're seeing a node which looked grossly like a mucoid node, or it looked grayish white, and therefore you have sampled it, and you have found that this node, this was clearly a node, but it's just full of mucin pools, and then you have gone on to seeing whether this patient had received neoadjuvant therapy, and they have clearly told you that this is it's actually therapy naive. That means the patient has not received any adjuvant therapy. Now, what do? We know that mucin in a node is not normal. So does this mean metastasis? Or how do we explain this, the presence of this acellular mucin, which is there within the node? So currently, there are no recommendations as to how we need to handle, but UICC has said that acellular mucin pools in a lymph node should be considered positive for tumor if there has been no previous history of neoadjuvant therapy. So I think that is what we would have to say at the end, provided we've taken step sections. So something like this, I would take multiple deeper levels and even do an IHC to try and identify any occult tumor cells that may be there within the node. So therefore, when we look at stage 2 colorectal cancers, that means it's either a T3 or a T4 and it's node negative. There are certain indications which would warrant that this patient should receive adjuvant chemotherapy. Now that includes a poorly differentiated histology, lymphovascular invasion, PNI, a localized perforation, if the margins are positive or indeterminate, less than 12 lymph nodes and tumor budding. So all of this, if poorly differentiated histology, it depends, that we would see under the microscope. But as you can see, even under gross level, LVI and a localized perforation, the margin status, the lymph node examination, all of that directly reflects our grossing and grossing techniques. Tumor budding has already been alluded to, so I will not go through much into this. It has already been discussed, but what we do is that we will try and identify these hotspots, look at them at a times 20 and give the score. So this is just roughly to say that 0 to 4 buds, that's BD1, BD2 and BD3. So why is tumor budding important? I think we had just heard in the previous talk that Dr. Anuradha has clearly told us the importance of tumor budding in malignant polyps. But tumor budding is also important in stage 2 colorectal cancer. That is, it's not the BD1 or the BD2, but rather the BD3 identifies a subset of stage 2 colorectal cancer, which can behave aggressively and therefore would benefit from adjuvant chemotherapy. So really in stage 2 colorectal cancer, it's the BD3, that is buds more than 10 per 20 high power field, would warrant adjuvant chemotherapy. There are challenges, however, as with everything else. Sometimes they could just be reactive stromal cells or histiocytes that may be that makes it difficult to distinguish from buds that could be marked inflammation. And one can resort to IHC, the CK, to identify whether they are actually tumor buds or not, but finally go back to the HNA to try and make this assessment. And then finally, we will come to how do we deal with post-NACT specimens. So this, as you can see, is a post-NACT rectal resection. It was an LAR, and on opening, it was difficult to identify the tumor, although the resident said that there was no tumor. But if you look carefully enough, there is actually a very small area of ulceration. In fact, this is at the anterior wall, and clearly, this was not visible, so it has been cut open. And we have identified that there was a small area of ulceration. So clearly what NACT does is that it downsizes the tumor, and then the specimen comes to us. So we make this assessment, which is again important for prognostication. And in these NACT specimens, what we are trying to assess is the regression grading, the tumor regression grading, which is an independent risk factor. Also, we are now also aware that these specimens would have a poor lymph node yield. So that's the specimen to show that there could be either you may not see anything at all, if that's a complete regression, or we can see some small areas of ulceration. So it really pay good and close attention to the gross to identify that area, because if you don't see anything at all, then you're not quite sure where to sample from. And if that were the case, you're just seeing a completely normal mucosa. You want to be very sure on where you are sampling. Go back and have a look at the MRI, identify where that primary tumor site was, and then try and localize that on your specimen. And that's probably going to give you the best chances to identify any form of residual tumor. Or it can look something like this with a lot of ulceration. Again, are you going to sample this entire tumor bed? This tumor bed, the entire ulcerated area, is entirely, depending on the size of the ulcer. But ideally, at least about 5 blocks of that site is recommended. If it was otherwise, put the whole thing through. If it was something as small as this, I would suggest that you would put this entire area through and also go take 2 steps above and 2 sections below also. So this is our tumor regression grade, which I'm sure you are all aware of. And in fact, I just want to go back to this specimen. So this was the ulcerated area that we saw, and the entire ulcer was put through. I must say that on the initial sections, there was absolutely no tumor. So, which is not uncommon. You could see an ulcerated area, and then you've sampled that entire ulcerated area, and there is no tumor. So are you going to put that as a complete pathological resection, a complete pathological response? Yes, you can, but provided you have looked at it at multiple deeper levels also. So really, one needs to block that entire area, or if it's a very large ulcer, at least have 5 blocks of the tumor of that ulcerated area, and then our intention is to look for other residue tumor cells. So in this particular case, it was only on several deeper levels. I think it was on the 3rd or the 4th deeper level that there was a focus of residual tumor. So you can see these glands, which is there within the muscle layer. So this fell into a TRG1. And so this is exactly what I was saying. If no residual tumor can be recognized, we should look at that entire tumor area at multiple deeper levels. And despite that, there is still no tumor, then we can safely say that this is complete pathological response. Now, when it comes to the pathological response, there are various responses that the tissue reacts. It could be in the form of fibrosis, in the form of calcification, in the form of inflammatory infiltrate, and sometimes we even see osseous metaplasia. That's a node. I'm sure you would all agree that this is a node, and it has a contour of a node. There is some lymphoid aggregates in here. And if you were to look carefully, I'm sorry, I don't have a higher power of this. It just shows dense hyalinization, calcification, and some inflammatory infiltrate, but no viable tumor. So when it comes to tumor regression grading, we are really assessing we are only assessing the viable tumor cells and not the regressive changes that one sees. So I just thought I would end with just 3 clinical scenarios, and this is all pertaining to a post-neoadjuvant specimen. Now you've got a case like this, whereby and you've seen that area of ulceration. You've taken sections through. There are large mucin pools. In fact, these mucin pools are seen in the submucosa. That's the muscularis propria, and we've got pools that is dissecting beyond the muscularis propria also. So are we going to call this? So that is the situation. And then on deeper sections, we identify that there were some residual small clusters of tumor cells that was there in the mucin pools within the submucosa. So would this be a T1 or a T2? Okay, so I just want you to think about it, that we are actually grading, we are looking at the viable tumor cells. So in this particular case, there we've got the viable tumor cells, which was there in the submucosa, and hence it would be a T2. Sorry, a T1. Whereas we have got these acellular mucin pools that was pushing its way into the muscularis propria without viable tumor cells. So that does not put it into a T2, but rather a T1 category, because the viable tumor cells were still in the submucosa. Now, another scenario here where we've got mucin pools that is pushing its way beyond the muscle layer with some viable tumor cells here. That is the radial margin, and we've got a clearance of at least 2 millimeters or more than a millimeter. So is that R0 or an R1? So an acellular mucin at the radial margin does not make it into a positive margin. We need to see the viable tumor cells. So for tumor regression grading and for the staging, we are looking at the viable tumor cells and not at the acellular mucin pools. So acellular mucin pools at this resection margin would represent a negative resection margin. Another scenario, we've got a lymph node with lots of therapy-related changes. There's a lot of mucin pools and also a few residual, just a few clusters of tumor cells that's less than 0.2. So is that an N0 or an N1? So in a post NACT setting, it would qualify as residual tumor cells and therefore N1. So any amount of tumor in the lymph node is classified as a YPT, YPN1. So this is roughly how we would make our report based on our glossing of the colorectal specimens. So to conclude, I have tried to address the common challenges and the misconceptions, and have introduced some new concepts in our assessment of colorectal specimens. And the reason why we need to know this is because it just improves the quality of our work and the consistency of all what we are all doing across the country. And as we know, a high quality pathology reporting is essential for prognostication and for patient management. So for any further doubt, please feel free to look at our article, which was published last year. And Dr. Sanjeev Kati was here yesterday, so I'm sure you've heard him. So on that note, I would like to close our talk today. Thank you.
Thank you very much, Dr. Rupa. It was very, very comprehensive, and you have gone into the controversial area as well, and you have addressed to that. But there are a few questions, I think, about those. Can you take up these questions in the chat box? Some of them. Can you see them in the chat box? I say mainly about I think the mucin pools. I think another one is on the serosa about the mucin pools in the post chemotherapy cases.
Sorry, Madam I've lost. Can you see me?
Yeah,
can you see? Oh, okay. I think I lost connection for a bit. What did you say, Madam?
There are a few questions in the chat box. Can you see the chat box?
No, I've lost the screen actually.
Okay, you lost the screen.
Yeah.
It's about the presence of mucin on the serosal aspect in the post-chemotherapy cases.
Okay. It's about the presence of mucin in the
serosa.
Okay.
Post-treated case.
Yeah. So importance of seeing these mucin pools is that well, it is a response to the therapy. So one should look at multiple deeper levels to see whether there is any viable tumor cells, and also if you are confident or if you've sufficiently seen that there are no tumor cells, then it actually means that it is a negative margin. Do mention that you are seeing mucin pools at the serosal surface, but no viable tumor cells. So you can stage it up to the point that you have seen viable tumor cells.
So there are quite a few other questions regarding the mucin. I think it clarifies, isn't it? If you are not seeing any viable tumor cells, then it's going to be taken as negative, especially in post-treated cases. I think. Then another question is the sarcoid reactions in draining lymph nodes in colorectal cancer. How do you report? Do you perform CK on these or not?
Sorry, madam, please can you say that again?
Sarcoid-like reaction in a lymph node in colorectal cancer.
Okay.
How do you report? Do you perform CK, cytokeratin on these or not?
Okay. So you mean to say a granulomatous response in a lymph node?
Possibly sarcoidal reaction.
Yeah. So a granulomatous response, it is not uncommon to see a granulomatous response, especially to tumor or even to mucin reaction. So if one were to, you should, I always resort, if in doubt, just take a few deeper levels and see whether there is any tumor cells, or it might even highlight the granulomatous, the granulomas even better, because sometimes you can see some necrosis within the granulomas. So one should be alerted and do special stains.
I think, okay, everybody is thanking you after that. Yeah, it was a wonderful talk, Dr. Rupa. I think with that, we close this particular session and go to the next one. Thank you very much, Rupa.
Thank you. Thank you.
Okay, we go to the next session, which is Whipple's resected specimens, and it's going to be presented by Dr. Kanyappan from New Delhi. Okay. Kanyappan, have you? Achha, he is there. Are
Yes, ma'am. Yes, ma'am. I'm there. Yeah.
Come. Chalo. You going to share your presentation, or you want us to present? We have your presentation also.
I'll share my presentation. I'll share.
Okay, you share your presentation then.
Is my screen visible?
It's yet to come. We can see you, but not your presentation. Yeah, it's coming.
Yeah.
Yeah, we can see it.
So a very good afternoon all again. Happy to see you all again. And again, I would like to thank the organizers for inviting me for this talk. Today, I'll be discussing briefly about the grossing of pancreatic or duodenectomy specimen, that is a Whipple procedure. And I'll be discussing in following heading, introduction with a small note about the normal anatomy and clinical information required on the specimen request form, grossing, and brief about reporting format and silent features of microscopic findings. Again, Whipple's resection is a very complex specimen, and I would like to mention that each institute or each setup follows different procedures for dissection and margins and lymph node sampling, and then terminologies are also varies from place to place. So there is no ideal standardized technique for that can be uniformly followed everywhere, and it is up to the institute to standardize a particular technique and then follow that technique for the purpose of reporting. So anatomy, since we the Whipple's resections will be containing the head of the pancreas, I'll describe in detail about the anatomy of head of the pancreas. So pancreas, as you all know, it is a retroperitoneal organ. It has an anterior surface and posterior surface. Anterior surface of head of the pancreas is covered by peritoneum, and it is a free surface. It is not in contact with any of the any other organs. The right side of the pancreas is in direct contact with the second part of the duodenum, and if you see the posterior surface, the posterior surface is actually directly lies in contact with the retroperitoneal fat. It is loosely adherent. It is not tightly adherent. It is loosely adherent to the retroperitoneal fat. And the posterior surface, it has some important relationship with the blood vessels. The superior mesenteric vein, which is I am highlighting now, and the splenic vein joins to form portal vein at the posterior surface of the head of the pancreas. So the superior mesenteric vein and the splenic vein joins to form portal vein at the posterior surface of the pancreas. And this impression of superior mesenteric vein and the portal vein forms a groove in the posterior surface of the pancreas, and it is an important landmark for the surgeon as well as the surgical pathologist. And the superior mesenteric artery, which is partially cut here, is in close relationship with the uncinate process. So this is the uncinate process, and it is in close relationship with the uncinate process of the pancreas. The splenic vein is located posterior-superiorly to the pancreas. So this covers the most important surgical anatomy that you should be aware when dealing with the Whipple's resection. And the other important point is to know about the ductal system. So the ductal system may be divided into two. That is the common bile duct, which has an extra pancreatic part and the intrapancreatic part, and the pancreatic ductal system, which mainly is composed of main pancreatic duct, and sometimes you can have an accessory pancreatic duct. The common bile duct combines with the main pancreatic duct at the ampulla of Vater, and it opens in the duodenum at major duodenal papillae, which can be grossly visible. And the accessory pancreatic duct opens at the minor duodenal papillae, which is situated usually 2 centimeter proximal to the major duodenal papillae. So what are the clinical information that you should be aware before opening your specimen? So you should know about the age, gender, any previous surgery or malignancies, whether or not preoperative therapy has been given, the nature of the dissection specimen, presumed site and type of the tumor, a diagram of surgical procedure or a good clinical description can be very valuable in case of a complex specimen, and Whipples, especially if it is there, it always helps the resident who is grossing. If you are still in doubt, clarification should always be sought from the surgeon. Just call him and then identify the unidentified structures. Do not gross anything if you have any unidentified structures. Otherwise, you may not be able to trace it back, and it will lead to a lot of confusion. So you should also be aware of the commonest indications why Whipple's resection is done. Unless if you are not aware, you won't be able to locate the lesion. So the commonest indications are lesions located in pancreas, like carcinoma, head of pancreas, cystic tumors of pancreas, or chronic pancreatitis, which causes obstructive features, and lesions located in the ductal system, like carcinoma ampulla of Vater or carcinoma of distal bile duct, and also the duodenal cancers in the second part of the duodenum. So what are the types of resection specimen? There are three common types of Whipple's resection specimen or pancreatic or duodenectomy. The classical and commonest one is also known as Cox-Whipple's pancreatic or duodenectomy, and the next one is pylorus preserving pancreatic or duodenectomy, and the last one is a total pancreatic or duodenectomy. What are the components of classical or Cox-Whipple pancreatic or duodenectomy? So you will have a distal part of stomach, duodenum, some part of jejunum may be there, head of the pancreas, cystic duct, gallbladder, and common bile duct. So these are the structures that you should externally see and identify in a case of classical pancreatic or duodenectomy specimen. In pylorus preserving specimen, you just don't see the stomach in the specimen, and rest all the specimens will be included. Gallbladder may be attached, or it can be sent separately as well. And the last specimen is total pancreatic or duodenectomy, where you have, in addition to the other structures, you also have the body of pancreas as well as the tail of the pancreas, and spleen may or may not be included during the resection. The extended pancreatic or duodenectomy is never or seldom followed done these days, which included previously extensive resection of retroperitoneal lymph nodes. Coming to the grossing. So before grossing, you need to prepare, before dissection, you need to prepare the specimen. So how will you prepare the specimen? First, you should orient the sample, paint the margins, dissect it. If the sample is needs any fixation prior to fixation, you should dissect it, or you can directly fix it if doesn't need any. If the tumor is not so much bulky, you can fix the sample. So how to orient the sample? So first you need to identify the surface, anterior and posterior surface of the pancreas. So to know that, you should see some of the salient features, like the characteristic of adipose tissue attached to the pancreas, the relationship between duodenum and pancreas, and the pancreatico-duodenal groove. In case of anterior surface, the fatty surface is irregular, more irregular, and the bulk of the pancreas or fatty surface will bulge onto the duodenal surface. So the pancreatic or duodenal grooves, actually you can palpate it, and it is sharp in case of anterior free surface. Whereas if you see the posterior surface, the posterior surface of the pancreas is relatively smooth, and the transition between the duodenum and the pancreas is also smooth, and as a result, you don't see a sharply defined pancreatic or duodenal groove, and you can't easily palpate the posterior pancreatic or duodenal groove. And in the posterior superior aspect, you also see the opening of common bile duct. So this is how you identify the anterior and posterior surface. So the posterior surface is we don't use in case of resected specimen because it is not a surface. It has already become a margin since you have already dissected it out from the body. So please mention the posterior surface of the pancreas as posterior margin and don't tell it as a posterior surface. However, anterior surface is always free. So you can mention it as an anterior free surface. And the next thing that you will be identifying in the resected specimen is the medial surface. Look into the medial surface and identify some of the margins of the pancreas. So as I have described in the anatomy, the superior mesenteric vein and the portal vein related to the pancreas forms a groove. So this is the characteristic groove, which is smooth and it is concave. So smooth surface, shiny surface, grooved surface is where the superior mesenteric vein and portal vein runs at the posterior side of the pancreas. And the next thing you should identify is the pancreatic neck margin. So the pancreatic neck margin is the one which surgeons transect the head of the pancreas from the rest of the pancreas. So this is the pancreatic neck margin, and the below the superior mesenteric vein groove is that we have superior mesenteric artery margin. So this is the part of the pancreas which lies in close relationship with the superior mesenteric artery. So this is the superior mesenteric artery margin. So if you draw a line, so again this is a pancreatic neck margin, and this is the superior mesenteric vein or the vascular groove margin, and this is the superior mesenteric artery margin. So if you draw a line in the pancreatic neck margin and straight line in the pancreatic neck margin and a straight line in the superior mesenteric artery margin, both of the lines converge towards the superior aspect, whereas they diverge towards the inferior aspect. So this is the inferior aspect, this is the superior aspect, and here again this is the superior aspect and this is the inferior aspect. And if you connect these lines, it will form a trapezoid. So this trapezoid structure can be used as an important landmark for orientation of the specimen. And again, in the medial surface, you should also try to look for ductal structures. So this is the pancreatic neck margin, and you can see the pancreatic duct, which is highlighted, which is circled green, and the in the posterior superior aspect, or you can say that the upper right edge of superior mesenteric artery margin. So this is the superior mesenteric artery margin, and at the upper right part of the superior mesenteric artery margin, you can find the common bile duct resection. And usually it is tagged with a suture, so it is easy to identify. However, the pancreatic ductal margin or orifice is difficult to identify as it is smaller than common bile duct, and it is difficult to probe as well. And usually it is located at the upper right quadrant of the pancreatic neck margin. So once you have identified all the important landmarks and oriented the specimen, you will open the specimen. So open the specimen. To open the specimen, resect the sutured gastric as well as the duodenal margins, and then cut open the distal part of the stomach along the lesser curvature, and also the entire length of the duodenum along the antimesenteric border or opposite to the pancreas. And then you should look for the mucosal lesions in the duodenum. So, and especially you should examine the ampullary region very carefully to look for and identify any mucosal abnormality or a polyp or a grossly visible tumor in this ampullary region. Sometimes you might identify accessory pancreatic duct opening or minor duodenal papillae also proximal to the major duodenal papillae. So major duodenal papillae is identified easily, you can palpate is easily, and also it is visible as a projection into the duodenal lumen. So once you have identified, dissected the duodenum, you should now try to dissect. If your pancreatic tumor is bulky and it needs fixation, you should dissect the specimen. But before dissection, you should always try to before cutting the specimen, you should also always try to color code the margins, and then so that it can be identified later. So it also depends upon the preference of the institute and the sector. Either you can paint before fixation or after fixation, but it is important to note that sometimes there might be seepage of paint into the cut surface of the tumor if you have not painted it before fixation. So once you have color coded, you should always try to use different colors for different margins as shown in this image. And you should also try to color code, identify any other important structures. For example, the surgeon might send a portal vein or superior mesenteric vein along with the specimen if he suspects there is an involvement of the vascular structures. So in that case, you should also try to paint all the circumference of the veins that has been resected. So here the probe actually inside the lumen of the blood vessel, and it is also painted circumferentially. So you should also paint the anterior surface and the posterior pancreatic margin. So and once you have painted, the specimen may be partially sectioned into two halves as per the dissection technique, which I will be discussing later. And then to allow adequate fixation, I should partially dissect the specimen and then fix the specimen for 24 to 48 hours. So the next day you will take out the sample and then try to take sections from the resection margins first. And the margins, there are numerous margins, about 7 margins that you need to take in case of Whipple's resection. And the number of margins that you will be dissecting prior to cutting the sample depends upon the technique used, as well as the it depends upon, it is left for the preference of the dissector and the reporting pathologist. So you should further do parallel cuts to examine the pancreas to identify the lesions exactly where they are located, and its relationship with the ductal structures of the pancreas and distal bile duct. So what are the margins that we are going to take? This is an important area, and there is a lot of confusions and debate over the terminologies and nomenclature of margins. So this is the margins that has been suggested. These are the margins that has been suggested by the Royal College of Pathologists guideline, according to the Royal College of Pathologists guideline. So we have two margins, that is transection margin and dissection or mobilization margin. Transection margin are the margins where surgeon transversely cut and then take out the pancreas, dissecting it from the other organs inside the body. So transection margins are pancreatic neck margin, common bile duct margin, superior mesenteric artery margins. That is the rough area to the left of superior mesenteric vein, and jejunal or duodenal margin or and the gastric resection margin. So these are the transection margins. I'll repeat again. Transection margins are the margins where the surgeons cut transversely and dissect the resected specimen from the rest of the organs inside the body. They are pancreatic neck, common bile duct, superior mesenteric artery, jejunal, stomach, and duodenal margin. The next margin is the dissection or mobilization margins. So these are easily dissected out. Surgeons don't have to transect it or transversely cut. They can be easily dissected out or just by mobilizing the structures. So there are two margins in this category. One is superior mesenteric vein margin, which is a smooth groove-like surface at the posterior part of the pancreas, and other one is the posterior margin, that is posterior pancreatic margin. So this lies over the aortocable groove. This is also the smooth surface that we have already discussed during the orientation of this specimen. Next, special margins. So as I said, sometimes surgeon might send a vein along with the specimen. So in that case, we should also take sections from the veins as well. So if the surgeon has sent you the end block transection, end block specimen of the vein, that is complete circumference of the vein, then you should take transection margins of the veins. If it is just a lateral sleeve of the vein, then you should take the entire edge of the margin, edge of the vein where the surgeon has actually cut. Next is the anterior surface of the pancreas. Anterior surface, please note that anterior surface of the pancreas is not a margin at all. It is just a surface. However, you should paint the surface because it is noted that if there is an involvement of anterior surface of the pancreas, there is increased chance of local recurrence. So you should also paint the surface. So again, I'll highlight the margins that we have been talking about. This is the bile duct margin, proximal duodenal or gastric margin, distal duodenal margin, pancreatic neck margin, superior mesenteric vessel margin, which includes superior mesenteric vein margin and superior mesenteric artery margin. So how to take margins? So it is ideal to use perpendicular margins rather than taking a shaved off margin in cases of especially in cases of the medial surface of the medial side of the pancreas. For example, this is a superior mesenteric artery margin which has been painted already, and you can identify the smooth groove-like surface which is superior mesenteric vein margin. So this has been painted, and try to dissect entirely along parallel to the superior mesenteric artery margin. So you take out whole of the superior mesenteric artery margin out, and once and the thickness should be 3 to 5 mm. And once you take out the whole of the margin, you can divide the specimen into multiple cuts perpendicular to the superior mesenteric artery margin. So you can divide the specimen like this. And then you can embed in all of the margin in a cassette. So as I said, the Royal College of Pathology's guidelines suggest use of these following terminologies, as there is a lot of confusion over the terminologies of margins. So superior mesenteric vessel margin, which includes superior mesenteric vein margin and superior mesenteric artery margin, posterior margin, that is posterior pancreatic margin, and proximal duodenal or gastric margin, distal duodenal or jejunal margin, pancreatic neck margin, bile duct margin, common bile duct margin, and the anterior free surface of the pancreas. For example, the superior mesenteric artery margin have been given various terminologies like uncinate margin, retroperitoneal margin, inferior posterior retroperitoneal margin, and lots of other names. So it is not recommended to use these terminologies anymore, and these are the standard terminologies that one should follow. Coming to the dissection techniques. So the dissection techniques, the most commonly used ones are the bivalving method and the axial sectioning. Sometimes we can use bread loafing and the other kind of resection as shown in the dissection as shown in the image. So we will discuss the most commonly used technique, that is axial technique. So in axial technique, after orienting, painting, and fixing the specimen, you will be cutting the specimen into multiple parallel slices, and by cutting the pancreas perpendicular to the long axis. So this is the long axis of duodenum. So duodenum runs like this, and you will cut the pancreas into multiple slices perpendicular to the long axis of pancreas. So in the perpendicular slices, try to include the ampulla section, so that you will able to identify the ampulla and the distal CBD in your microscopy examination. So this is how the multiple parallel slices look in axial sectioning. So once you section, you should try to arrange these in order from above to below, and then you should label with numbers, and then take a nice photograph of this. There are two options available for you. Either you can submit the entire dissected sample, or you can identify a particular lesion and then submit only those sections that are needed. So if you are in both situations, you need to take photograph, because you may not be able to orient the specimen back after dissecting, and most of the times you need to relook the specimen after seeing any additional finding in the microscopy examination. And take a close-up image of any sections having a lesion. So if you are leaving some of the specimens in the container, then try to label the specimen and fold it in a paper and label, and then keep it nicely so that it can be oriented later as well. Next is the bivalving technique. So in bivalving technique, what we do is probe the common bile duct. So this is the common bile duct, as well as the major pancreatic duct. So this is the major pancreatic duct, and a parallel cut is made along these probes and dividing the pancreas into two halves. So this is the bivalving technique. So in bivalving technique, you will be having two halves. So this is a representation of one of the half of bivalving technique, and you can see that the distinctive nature of the ductal system that can be appreciated in this technique actually. So this has a greatest advantage of easily identifiable lesion, easy to identify any lesion situated along the ductal system. So once you have divided the two pancreas into two halves, you can further divide the specimen to take more sections into using three different techniques. Either you can do parallel slicing and divide the specimen further, or you can try to cut the specimen axially. So this further you can divide the specimen into multiple axial sections and take sections, or you can do bread loafing of the pancreas and take sections. So it entirely depends upon the lesion that you are going to identify in the specimen, and the interest of pathologists to cover to find out the relationship of tumors with the adjacent structures. So what are the salient features of both of these common techniques? So axial sectioning has been followed most prevalently because it is less technically demanding. So you can easily train anyone, any technicians or resident to do axial sectioning. However, bivalving technique involves little technical difficulties, and probing of pancreatic duct is not always possible. And visualization, however, the visualization of the ampullary and periampullary region are better in case of bivalving technique, and also visualization of ductal system is also much better in bivalving technique. However, the accessible nature of the margins, the circumferential margin that we have been described, is more complete and easier in case of axial sectioning. However, it is less when prominent in case of bivalving technique. So the pancreas sometimes need to be completely submitted in total in case of axial sectioning, whereas it is not required in case of bivalving technique. And however, there is a chance of doubling of lymph node count in case of axial sectioning, which is much less in case of bivalving technique. So if you axially slice the pancreas and put a section, there is a high chance that a single lymph node is transected into multiple times, and then you will count it as 2 lymph nodes rather than 1 lymph node. So other techniques that can be followed in special situations, like if you receive a specimen of distal pancreatectomy specimen, you can use multiple sagittal slices. That is a bread loafing technique to identify the lesions. And in case of a total pancreatectomy specimen, you can use a combined axial slicing and CT slicing technique. So next, once you have dissected and taken sections, you should look for the lymph nodes. So where are the places that you should be looking for the lymph nodes? So you have a group of lymph nodes, different group of lymph nodes situated along the different surfaces of the pancreas. They are divided into superior pancreatic nodes, inferior pancreatic nodes, then pancreatic or duodenal nodes, and pyloric group of nodes. So these are the nodes that you will be getting in the Whipple's resections. All others are not usually identified or not usually is attached with the Whipple's resection. In Whipple's resection, you will have superior pancreatic nodes, inferior pancreatic node, pyloric, and pancreatic or duodenal, which are again divided into superior, inferior, and again further divided into anterior and posterior. So you should try to identify these nodes at this specific location and try to label those lymph nodes and give it in a separate cassettes. And again, you have different techniques are used for lymph node harvesting. Either you can actively search, look for lymph nodes in each of those mentioned areas, or there is another technique which have yielded a better lymph node sampling, is the orange peeling method. And in this method, what we do is that all the free surface of the pancreatic head that have potentially harbor the lymph nodes are shaved off after inking the surface, and then they are sampled. So this system has yielded a better lymph node sampling. And in case for all Whipple's specimen, you should try to harvest at least 15 lymph nodes, and lymph node status is important for an important prognostic factor, as well as it helps in TNM staging. The next, so this is a photomicrograph, which this is a photograph actually showing a posterior surface or posterior view of the dissected Whipple's specimen. And this is the posterior pancreatic or duodenal groove here, and this is the orange peel technique, where the entire soft tissue, free surface of the pancreas has been dissected out, and it has been submitted for the lymph node sampling. So this is the photograph which highlights the orange peel technique used for lymph node sampling. And other important feature is that can you identify post-therapeutic changes grossly? So it has been seen that in a case of Whipple's resection, it is not reliable to identify these findings grossly. There has been lack of reliable features that you can surely rely on to identify the tumor regression or viable cancer. So what you need to do is that you should try to sample all the abnormal looking area rather than just localizing to any particular area. So after identifying all these, and after arranging your specimen and orienting a specimen and painting a specimen, you need to take sections. So what are the recommended sections that you need to do? So you should have at least 4 sections from the tumor, and the tumor sections, according to its location, you should try to include a tumor with an adjacent ampulla, common bile duct, or a duodenum, or the pancreatic head. Then you should also sample all abnormal looking or suspicious area. Try to look for cysts in pancreas and section those as well, and margins as I've mentioned before. And you can also take a section from an adjacent duodenum, pancreas, CBD or hepatic duct if included. Also take section from gallbladder and the lymph nodes. So this is the reporting format that has been recommended by the Royal College of Pathologists, UK. So gross features already we have covered, and the important microscopic feature as is that all the findings of that you have identified grossly has to be confirmed, especially the margins are to be confirmed microscopically. And it is also important to note the distance, exact distance of these margins from the tumor microscopically as well. So it is not just that you just mention it is positive or negative. You should also mention the exact distance from the resection margins. So this is standard format. I'm not going to discuss in detail. You can have a look at it. Another important issue that arises in microscopically is the assessment of R1 and R0. R0 is completely resectable, resected tumor, or R1 is where there is an incomplete microscopic excision. R1 is an incomplete microscopic resection. R2 is macroscopically positive resection margin. R0 is where the resection margin is confirmed free microscopically. So there has been a lot of studies and researches that have suggested various cutoff for calling a tumor as calling a resection margin as positive and negative. However, the RCP guideline says that carcinoma situated less than 1 mm from any resection margin are to be considered incomplete resected or R1. However, does this rule applies to the anterior surface of pancreas also? No, the anterior surface of pancreas is not a surgical margin. So this rule does not apply to the anterior surface of the pancreas. And anterior surface of the pancreas is considered positive only if there is a breach by the tumor. So this less than 1 mm is true for all the resected margins and not for the anterior surface of the pancreas. Then and another situation is that if you have a lymph node uh, uh, tumor, lymph node situated, positive lymph node situated within 1 mm of resection margin, or a tumor with the lymphovascular within the lymphovascular channel, or a perineural spread situated less than 1 mm. So in those situations also it is also considered that the tumor is incompletely excised. So these are the guidelines that has been put forth by the RCP Royal College of Pathologists. And although there are less evidence for this, further studies are being done, and we might expect further standardization in the upcoming years. Direct again, another situation is that if you have a lymph node which is directly involved by direct infiltration of the adjacent tumor, should we count it as a positive lymph node or not? So in this special situation, it has been found that there is no difference in survival of the patient with direct invasion versus those of lymph node metastasis. So if you have a tumor which is infiltrating directly into the adjacent lymph node, just count those lymph node as a positive lymph node and include those count in the total number of lymph node positivity. And again, you have various grades that has been followed for assessment of tumor regression. This is the CAP regression system, and there is another regression grading system proposed by Chatterjee et al. So you can use any of the grading system according to your institute, but please mention the exact name of the system along with your report. Another special mention that needs in case of Whipple's resection is that ampullary definition of ampullary tumors. So the tumors of ampulla of Vetter may arise either in the ampulla or on the duodenal surface. So if it arrives in the ampulla, it is intra-ampullary type, or if it arises in the duodenal surface, it is periampullary type. So periampullary region is just approximately 1.5 centimeter in diameter around the ampulla of Vater. So sometimes you can have a tumor which involves both intra-ampullary and periampullary region. In that case, you will just mention it as a mixed type. So it is important to identify the tumor origin grossly as well as microscopically, because of prognostic purpose, as well as the TNM staging also varies according to the tumor location. So these are my references that I have used in preparing the techniques, and you can have a look at it, the video links that I have mentioned here. And if possible, ma'am, shall I show a video here, or is it?
So.
Okay, I'll just.
Dikho. You already got ready with that. Another few minutes only.
So this is a video that has been already in the website in the Australian Royal College of Pathology Society of Australia, Royal College of Pathologists of Australia. So this is the video link for orientation of the specimen.
Here, huh?
Is the audio also?
Audio, we can't hear anything. We can
okay.
just see the video.
See the video. I'll just highlight the. I'll just tell the audio that has been. So this is the pancreatic. So this is the pancreatic neck resection margin. So superior mesenteric vein margin. So this is smooth grooved surface, posterior medial surface. So this is the superior mesenteric artery margin. This is the anterior surface, and this is the posterior pancreatic margin. And a little about the dissection of the pancreas. Here, the video describes the axial sectioning of the axial sectioning technique here. So the pancreatic dissection margin is painted yellow, and the superior mesenteric vein margin is dissected blue. and superior mesenteric artery margin is dissected red. And then anterior surface is painted green. And the posterior pancreatic margin is painted black. So duodenal margin and the are taken as a shaved off margin. Duodenal gastric margins, cystic duct and bile duct margins are also taken as a shaved off margin. So this is the axial technique that I have described. So it's just a multiple perpendicular cuts to the longitudinal axis of the duodenum. So identify the ampulla, keep it as a landmark, and then cut it at the ampulla, and then try to cut into multiple slices from there. You can either start the cut either from the duodenal surface or from the pancreatic surface. So arrange serially, write the orientation in your dissection board. Identify the lesion, measure, and then try to block. So submit it. Hope the video is useful. You can have the view of entire video with the links provided, and you can easily access with the in their website, Royal College of Pathologists of Australia. And I would like to thank again the organizing team and the audience for the patience listening. I'd be happy to answer any of your doubts here. Thank you.
Chat box, I think it's nothing much. Only the audio problem. I think your presentation was so lucid, Kanepal. So
Thank you.
nobody has so much of query to ask you. I think it was really lucid. You have really put in a lot of effort to make it very clear. Everybody is thanking you, including Vista. So we also say thank you.
Thank you. Thank you so much.
Very much for that lucid presentation. And I am sure that you have put in a lot of effort to come up with that kind of presentation. Thank you very much, Kanepal. Thank you very much.
Thank you.
I think we close this session. And now we go to the last session where there is vote of thanks and any other important logistic issues. So I think Ritambra, are you in? Chalo, you take over. इसका रिटामरा का अनम्यूट पर है अच्छा अच्छा चलो ठीक वो बात करेंगे ना चलो कोई we can't hear you but if you are talking.
And good afternoon everybody. Ma'am, am I audible?
Yeah, now we can hear you.
Okay. So I've been given the pleasant duty of proposing a vote of thanks of this great CME. And to begin with, I would like to thank our main organizing body, that is IAPM, for giving us this opportunity on behalf of our organizing committee. And for the local logistics, I think we place on record our thanks to our professor and head, Professor B.D. Radotra, because he has been very supportive right from the inception, from planning and execution of whole program. And I think special thanks to our faculty who have spent their very precious time from the busy schedule for and prepared such great talks and shared their experience of so many years with our young colleagues who must have really been benefited by this whole endeavor. And also the young faculty, young masters who were really bubbling with knowledge. And I think our listeners must have had very good resource material from them. And at this point, I really appreciate and thank on their behalf to the thoughtfulness of Ma'am Kim, because this thoughtful gesture of giving them a push at this stage of career really means a lot. And I think this will become a permanent kind of a memorable memory in their academic whole career. Thank you, ma'am, for this kind of a thoughtfulness. It was really
Thank you.
never kind of experienced this kind of a gesture earlier. Great. And in all such these virtual CMEs, I think another important aspect is audiovisual and the internet facilities. And I think our institute's telemedicine and computer department has done a wonderful job. We had very smooth running of the whole event, except for one or two glitches, which is kind of expected. And I want to place on record special thanks to Mr. Lal Bahadur and from that computer center, and Mr. Pankaj from telemedicine, I think, who have been really working very hard for this event. Thank you, both of you, from our organizing committee. And as is always said, such meetings are success only because of delegates. And as ma'am yesterday mentioned, that we had a very overwhelming response, close to 550 delegates for a single subject meeting in meeting and workshop. It's a great number. We are happy for that. But we would like to have your truthful feedback, as ma'am was saying, a detailed feedback, because this will help us improve in our future endeavors. So please do give your positive and negative both feedback, because both are valuable for improving. And I think that's all I have to say as far as vote of thank is concerned. I would hand over the mic to Kim ma'am for any last minute points to be made. And thank you all, and play safe, follow all COVID appropriate behavior, because we're expecting the third wave. So just be safe so that we can meet soon again in our next meetings. Thank you so much. And ma'am, if you want to add something.
I think nothing really much to add. I think many people, even today, maybe 10:30, 11 o'clock, wanting their registration, possibly that was mainly for to get a certificate. I feel, according to me, I won't really encourage such kind of attitude. If you are really interested, because you all are postgraduate students, as a teacher, I will not encourage that kind of attitude. If just getting the certificate is not really, will not really help you in any way. The real challenge would be what you do in day to day with honesty and with sincerity. I will advise the PG especially, and also the young faculties, to be sincere in your attitude, in your thinkings, in everything. Sincerity, you cannot compromise in order to do well in your life. I think we have come up to these states, and you have seen many of the senior faculties who have spoken, given their views and their experiences. All those they have achieved over the years, 30 years, 40 years experience. It's not one day or 1 month. And I have shown also Dr. Prasanjit's biodata, especially the awards which he has been getting, or he has got still so far. And I have seen Prasanjit as a junior resident, and he is bubbling every day. He comes with new concepts. That's how he has achieved at this particular age. He's very young. So many awards and recognition. Everybody or every one of you also can do well like the way he has done in his life. And so I am taking him as an example to set an example so that all of you also can do. And So I think that's what I like to say to all of you, especially the PGs: honesty, transparency, and sincerity in your attitude, in your day-to-day life. And don't be impatient. Work hard. It will come to you ultimately at one fine day. I think that's all which we have to say about getting certificate. Is not the whole issue about this, and maintaining discipline, because registration was open, we extended by 3 days, and now just for the certificate, I feel some of you are still there, more than hundreds, is coming still so far. I don't think that that's a very good example. I don't appreciate, and I will not recommend that kind of attitude. I think with this word, I think we all have to say thank you to everyone who have registered, who have logged in, and who also had cooperated with us by spending their valuable times to deliver the lectures, to chair the sessions. And thank you all. Thank you all.
Dr. Kim, can I say something? Vatsala here. You cannot visualize my picture, some problem in the camera. I just want to thank you and congratulate you for organizing such an excellent CME.